which is in conjunction with Chinese Vascular Society, will be on June 20th at 8 o'clock in the morning. And the third part debates will be on June 27th, again at 8 o'clock in the morning, again with the Chinese Vascular Society in conjunction with them. So we have an incredible lineup of speakers today and moderators. I want to welcome Dr. Lovell Kabnik, Dr. Nilesh Balar, Dr. Parag Doshi, to help me moderate this session, along with all our speakers who has taken very valuable time out of their schedule to be on Saturday morning. So without further ado, let me introduce our first speaker on a very, very important topic related to paclitaxel, which you all know is a huge controversy. Dr. Sahil Parikh, who is the director of endovascular therapy at New York Presbyterian Hospital and Columbia University Medical Center in New York. He will take the pro side. Paclitaxel-coated stents are associated with increased mortality. It's all a matter of perspective. So I'll turn it over to you, Sahil, now. It's all you.
Raj, thanks so much for having me. When I was given the topic, I asked Raj if he didn't like me. I'm delighted to be here with Dr. Katsanos. These are my disclosures. And most importantly, I'm on the ACC. I'm the ACC representative for the RAPID program in the Multi-Society Paclitaxel Coalition. So until COVID hit, I've been thinking about this topic quite a lot. My other disclosure is that most of my prior life, before I started blowing up balloons for a living, was spent in basic science laboratories looking at vascular drug delivery. So a lot of my old talks used to look like this. But I'm going to try to spend some time today going over what the signal is. We'll talk about some concerns we have with these data and in which patient subsets do we see the signal. Are they claudicants? Are they CLI patients? And what do we see in other vascular beds, and what's our way forward? I will refrain from making any personal comments or dishing any dirt on my opponent or showing any funny pictures. And I know Dr. Katsanos is going to be able to present his data, but I'll try to start by talking a little bit about where drug-coated balloons and drug-eluting stents have been and where we are now. So I was one of the co-authors of the SKY consensus guidelines on FEMPOP, peripheral arterial disease intervention. And as you can see, drug-eluting technologies really have a class 1 indication based on the scientific data accumulated. These guidelines were issued right before Dr. Katsanos' meta-analysis in 2018. And as you can see on the right-hand panel, drug-eluting technologies had really taken a significant proportion of the market share of technologies for FEMPOP disease, over 50% in US VQI registry data. Then Dr. Katsanos' paper published in 2018 demonstrated that there was a mortality hazard. While there wasn't a difference at 1 year in a summary level meta-analysis, we started to see signal appearing at 2 years, and then subsequently at long-term follow-up, 4 to 5 years, with only limited data sets. There was a significant point estimate of 1.93 relative risk, or 93% excess hazard of mortality with patients treated with paclitaxel-coated devices. Admittedly, at that time, there was no clear association with any individual cause of death, and there was an analysis and dose response that I think was challenging. Subsequently, and many have seen this timeline, there's been a number of FDA guidance letters. A lot of meeting time like this has been spent talking about paclitaxel, and there have been 3 FDA letters to healthcare practitioners, the first in January and then subsequently in March, suggesting that we should seek alternative treatment. Then there was a flurry of activity culminating in an FDA panel meeting almost exactly a year ago that reviewed the data and suggested that there needs to be another warning letter, which was issued last August. And this was a little bit more cogent in its prescriptive nature. They did say that the data should be interpreted with caution, that there were wide confidence intervals, and that there was pooling of studies subsuming both stents and balloons, which have mechanistic differences. There was a huge emphasis on missing data, and many on the panel today have written about this or spoken about this, and so I'm sure we'll get some good discussion afterwards. And there was no clear dose effect identified in the FDA's analysis, and there's no individual pathophysiologic mechanism. And so subsequently, the rest of 2019, from a meeting calendar standpoint, was dominated by paclitaxel. And there was an important analysis from the Viva group that was initially presented in sort of draft form at a variety of meetings in the fall, where patients had been identified demonstrating a point estimate of not 1.93, but rather 1.38, using individual patient level data provided by the sponsors of the studies. With a variety of sensitivity analyses, this point estimate was attenuated. And so everybody's been waiting with bated breath since these data were presented to see this paper, which was published finally in May of 2020. For the purposes of the audience, I think it's most important to review this because this is really the most important and complete data set to date. And it does confirm the top line assessment from Dr. Katsanos that there is a 4.6% absolute risk increase in mortality at long-term follow-up in patients treated with paclitaxel devices. Here's the forest plot, and there's the Kaplan-Meier on the right-hand side of the screen for those who haven't seen the paper yet. I think it's important, and this was an opportunity for me to dig into the supplemental data. And then whereas the initial data sets that were presented showed 24 and 23% missing patients lost to follow-up at long-term follow-up for the control and paclitaxel groups respectively, we've now been able to find another 15% or so patients from each group. So the missing data are only 10% in the control group and 9% in the paclitaxel group. We in the coronary field would consider this unacceptable, but it is what it is, and that's subsuming most of the long-term trial data. I would point out, though, that the amount of patients missing is approximately the same as the number of patients who died in each of these groups of patients. And so we still have significant uncertainty about the mortality of those patients who are missing. And there are data, which I won't go into, that suggest patients lost to follow-up, particularly in these kinds of trials, have higher mortality rates than those that have maintained follow-up. So there's a lot of uncertainty about what the distribution of mortality in this missing set of data is. And my understanding is that industry has gone further and reduced this number substantially. The other thing that's worth pointing out here is that the other data that are maturing that were not presented here, specifically the Philips StellarX data and data from Boston Scientific for both Ranger and for Illuvia, are absent from this analysis. Mark Banaka, who's on our call today, used this slide to describe the challenges with missing data. And I presented similar data at the FDA panel, suggesting that this was going to be a key concern. The other thing as a pharmacodynamics and pharmacokinetics person that bothers me is that there is no dose response that's been identified. These are the data from the patient level analysis from Viva that was just published. I think it's fair to say that both the FDA and other regulatory bodies have sort of agreed that there is no significant dose response. One other point of concern, and this is buried in the supplement for the paper from last month, is that there was up to 40% crossover in the Zilver PTX group, with only a very small crossover in the Illuminate trial, but the average was still about a 10% crossover rate from control to paclitaxel, and there's really no easy way to account for this. So the number of patients exposed in both groups to paclitaxel is largely unknown for those patients who had crossover events, which were not recorded. So I've sort of taken the liberty to add this updated analysis. You can see the Viva NAMSA final is now 1.27 point estimate with error bars approaching unity. And this is in contradistinction to the real world data that are out there in the literature. Specifically, I'd highlight Eric Sisemski's work with the Medicare databases with very large data sets, suggesting that there isn't an increased hazard. This includes the surgical literature from VQI, and what's not shown here are the Barmer data from Germany. So global, different specialty, real world data all suggest that the point estimate of hazard is around unity, suggesting that perhaps there isn't any important signal in our clinical practices. And here's some data from Eric just to highlight that point. And what I think is important about this figure is that The mortality rate in CLI patients is not surprisingly much, much higher than those who are claudicants, but there is no significant difference when drug-eluting stents or non-drug-eluting stents are utilized in these patient populations at long-term follow-up in real-world data. The FDA agreed that there was no significant clustering of mortality hazard around any individual cause. These are summary comments from their own slides from the FDA panel, and I don't think that there's been any data compellingly presented subsequently that suggests that we can identify a single individual cause of mortality affiliated with paclitaxel. Dr. Katsanos and his team have subsequently presented and published data in JVIR, which I'm sure he'll talk about, in the CLI below knee population. And I would only point out here that the only significant, statistically significant signal was in decreased amputation-free survival in patients who received paclitaxel-eluting products. There wasn't a signal that was statistically significant for all-cause death or major amputations individually. And again, the sensitivity analysis don't show dose response other than for the composite rather than for mortality. They did show, importantly, that there was a TLR benefit in using these products, suggesting that the benefit value proposition remains in below-knee patients. In contradistinction to this analysis, Ramon Varco and his colleagues have recently published their data in a similar group of patients for below knee using a slightly more rigorous approach by taking only published and peer-reviewed data. And what they pointed out was not only is there a higher all-cause mortality in these patients at baseline, but at 6, 12, 24, and 36 months, and then finally at 60 months, using the IMPACT DEEP data set, there isn't a significant mortality increase in patients receiving paclitaxel-eluting products. And their sensitivity analyses likewise showed that there was no dose response. Back to the coronary literature again. So if we're looking at the infrapopliteal segment and the above knee segment, we go back to the coronary data just to remind everybody, while there has been increased stent thrombosis shown with paclitaxel-eluting stents and TLR, there hasn't been any convincing meta-analyses suggesting an increase in mortality hazard with these devices. I get asked this question by vascular surgeons all the time, so I think it's important to point out they always pick on the one outlier study that showed a difference in mortality, but if you really look across the board at all the other studies, there does not seem to be an increased hazard of mortality. So what about the benefit? I use this as an example just to suggest that we can predict in which patients we're going to see the highest rates of TLR using a variety of conventional risk factors. We also know that patients with CLI, for example, when they have restenosis, they get into trouble and have repeat CLI. So certain patient subsets are high risk for restenosis and have consequences that are important if they develop restenosis. The other thing that I think that's important to discuss is how do we take informed consent? It's important for us to make patients understand the relevant information. We need to present that with clear language that identifies risks as well as benefit, which we haven't talked enough about in the space. And then we need to document this. And so what I've been using for those that are interested is verbiage that's been adapted for our clinical trials, which I think is simple and easy for people to understand. And we're still using this as part of our standard approach to consenting patients when using these devices. I do think specifically in the CLI patient population where patients are older and have a higher actuarial mortality risk from their comorbid illnesses, I think the reduced TLR is valuable, and I think it's therefore reasonable to consider using these devices. That's why this is a matter of perspective. And so this is sort of how I frame the discussion. For CLI patients, I think it's reasonable to consider using drug-eluting technologies. For the older claudicant, who is really averse to repeat revascularization after informed consent, we'll consider it in those patients. And then we exercise caution, really spend some time talking with our younger patients, especially the claudicants, to discuss risk benefits and alternatives. A lot has been discussed about this. Many of us have blogged about it or written about it or spoken about it. And until COVID, it seemed like the only thing I got asked to talk about. I think our path forward is going to include the multi-society coalition of societies looking at this issue very carefully, which includes essentially every specialty here in the US taking care of these patients: surgeons, interventional radiologists, and interventional cardiologists. We're also deeply embedded in the FDA public-private partnership called the RAPID program, which is developing a statistical analysis plan to subsume all of the data and to provide guidance on informed consent and on the clinical data that are outstanding. Shown here on this slide are just a few of the many studies that are still waiting to mature so that we have more randomized, high quality data to include in our analysis. So with that, I would summarize that the signal is about a 4.6% absolute risk from the Viva IPD that's been recently published, accepting that about 10% of the patients or an equal number of patients are missing as are dead in those studies. I think the missingness in the crossover is a major concern that remains. We don't see a dose response, which pharmacodynamically is a real challenge to make us think that there's a causal relationship. There is, again, no individual cause of mortality, and it's not recapitulated in other vascular beds, either below knee or in the coronaries. We didn't really see this signal in the CLI clinical subset of patient populations. And so I think the way forward is to keep the trials going, pull as much data as we can, and use a smart statistical analysis plan that Eric can probably talk better about than me. And remember to discuss both the risk and the benefit with our patients before we use these devices. Thanks very much.
Thank you very much, Sahil, for that very superb presentation. Now to take the con side, I'd like to invite Dr. Constantino Katsanos, who is Professor of Radiology from Patras University in Greece, also the award winner for C3 2019 and our keynote speaker in the last live meeting. So he will now discuss paclitaxel-coated stents are associated with increased mortality. The signal is real.
Thank you very much, Raz. Thank you very much indeed for the kind invitation again. I think Sahil, Dr. Parikh has done a great job in summarizing key findings, key numbers, and also still the key uncertainties around this whole turmoil, which is definitely ranking second now after this whole COVID situation. So I hope everybody is still safe and well. Now, I'm going to be discussing a little bit more on more detail about paclitaxel-coated stents in particular, and I'm going to drift my talk in a slightly different direction. I don't have any disclosures with regards to the present presentation. Now, this is the summary. This is the latest summary of our findings with regards to paclitaxel-coated devices, and this is balloons and stents, and this is what we presented last June during the FDA. Those are time to event analysis to account also for patients rostered to follow up, etc. And basically, it comes down to a 62% increased risk of all-cause mortality out to 5 years, compared to a 42% decreased the risk of target lesion vascularization, pretty much from the very, very same trials, again out to 5 years. I'm going to take also here the opportunity to note that the whole thing about the reduction, the sort of the gradual reduction of the relative risk noted from 1.9 down to 1.62, perhaps down to 1.38 or 1.29 with the latest Viva data. Still, the confidence intervals are very, very wide. There is still a lot of overlap. So it's very, very difficult to make any sense whether this is actually a disappearing signal or whether this is like a consistent signal. And again, I don't want to discuss too much into statistics, but there is uncertainty, but there is also some statistical significance. Now, individual patient data, and this is very, very important. This is what we presented at the time, and this has been confirmed by the latest individual patient data analysis by Viva. So basically, like Parikh explained, 4.6% increased absolute risk of death out to 5 years. Now, back to the dose-response relationship, and this is very, very important. It is a very, very important part of the whole discussion. When we looked into 19 randomized trials with a non-parametric model out to 2 years, we had a borderline statistical significant finding of a dose-response relationship. That was highly significant out to 5 years. On the contrary, you may have noted that from the recent Viva publication, there was no dose-response relationship confirmed. I will note that we didn't have access to the individual patient data on one hand, and on the other hand, the Viva approach was a little bit of a mystery in terms of the statistical approach, because they basically standardized and centered the mean patient dose within each study before doing the meta-analysis. So that means that in the VIVA approach, someone who had 1 milligram on average of paclitaxel from the zero PTX study was considered to be the same like some patient who had around 4 milligrams of paclitaxel, which was the average dose in the Lutonix randomized study. And this complicates a lot. How do we combine the different dose ranges and the different means of paclitaxel dose between different studies? Now, why is it very, very important to sort of continue discussing the randomized studies? Because those are the only studies that can actually pinpoint a cause and effect relationship, and they can do what we call causal inference. This is the only way of prospective sort of controlling and cancelling out all the different confounders and being able to conclude that there is indeed a causal relationship between the explanatory and the response variables, like the same story when we explained that paclitaxel reduces target lesion and vascularization. Now, those are the main 4 randomized studies. They have been presented in the FDA meeting. On the top left-hand side, I'm going to highlight the zero PTX study, a borderline statistically significant finding, which was indeed statistically significant in the latest VIVA publication, so higher all-cause mortality on an intention to treat on the primary randomization. Now, I would like to spend a few minutes detailing some key findings here. The zero PTX randomized study was actually the only study that we did have access because Cook Medical was kind enough to put the individual patient data into the public domain. It is still very unfortunate that no other company has been able to put the individual patient data into the public domain for us to investigate as well. So when we did a standard Cox regression analysis, you can see here on the left-hand side that we did identify pretty much the standard predictors of mortality, like, for example, diabetes, CLI, AIDS at the very, very top, highly significant. On the left-hand side, you can see that the dose, the paclitaxel dose, was indeed, again, a significant independent predictor of mortality. The mean patient dose was 1.1 milligram. We divided that between control and 2 groups in the control treatment, in the interventional treatment. And you can see here a p-value of 0.028. So in the actual individual patient data Cox regression analysis, the zero PTX study did have a dose-effect relationship. Now, what about other subgroups? And this is very, very interesting here. If you have a look on the subgroup analysis, and of course, this is always post hoc, and we can discuss about multiple testing errors and everything, but it paints a very interesting picture. In the claudican group, we did have a significant signal of increased all-cause mortality. In the CLI subgroup, we didn't. Again, same story. When we had a look on the diabetes population, the diabetic patients didn't suffer from increased all-cause mortality, but there was increased all-cause mortality in the non-diabetic population enrolled in the zero PTX study, and the same, for example, also for the non-smokers compared to smokers. So in the presence of significant risk factors, we didn't pick up a mortality signal. It was the low risk population that seemed to paint the signal of increased all-cause mortality, at least in the zero PTX study. Now, we have to imagine this within the context of what we call competing risk analysis. So, for example, let's say we have one risk factor with a 5% risk of some kind of disease or condition. When we add another risk factor that has the same 5% risk of disease, then the observable risk ratio is gonna be calculated to be 1.95. Now, on the right-hand side, when we have multiple underlying risk factors, each one of them with a 5% risk, and we do the maths, actually the observable risk ratio of an added risk factor is going to be only 1.17. And this is because all the risk factors are competing for the very, very same outcomes. And it seems like something very, very similar is happening within the zero PTX study. Left-hand side, Cox regression analysis, after adjusting for a multiple or number of comorbidities, paclitaxel, highly significant predictor of mortality. Right-hand side, those are the number of risk factors. And you can see that between the two, I've got the Cox model interaction factor down here. There is a significant negative interaction between the two. So the more risk factors you have on one side, the less the chance that paclitaxel might come up as a significant predictor of mortality. And it probably means that there might be some negative interaction and some competing risk association. Now, we did spend a lot of time for the zero-PTX study. There are a few more data we need to discuss. We also have the XL-PAD study. We had some data published in the literature comparing the zero-PTX versus the bare metal stent in a PAD population, results only out to 1 year. Interesting there, they did an unadjusted and also a propensity-adjusted analysis around 1,000 patients. And again, the zero-PTX was associated with a significantly increased all-cause mortality. And in this case, this was out to 1 year. When you have a look at the causes of death, those are unfortunately or fortunately all over the place. So there is pretty much very, very little to be said about the actual causes of death here. What about the coronary literature? And again, there's so much data in the coronary literature, and we all tend to be a little bit selective in the ones that we tend to present in different meetings. Now, I have cherry-picked my favorite one, and this is the one with the meta-analysis of paclitaxel of the Taxus stents versus the Xience stents, because the Xience is, shall we say, the current new generation gold standard stent in the coronary circulation. And out to 3 years, there is a significantly higher all-cause mortality in the case of the Taxus stent out to 3 years. And again, you might note that the curves start to diverge after the first year. Admittedly, this is probably driven mostly because of the increased risk of cardiac death because of the coronary application of the devices. The same, I'm going to note, seems to apply also for the coronary paclitaxel-coated balloons versus the Olimus new generation drug-eluting stents. And again, you can see here that in the case of the paclitaxel-coated balloons, in case of small vessel disease, and this is a SCAR registry, there is a finding and there is a trend towards increased all-cause mortality in that patient population. Now, can we sort of speculate, is there any kind of explanation for those, shall we say, spooky signals of paclitaxel across the vascular board? And I'm not going to discuss the below-knee vessels here because we don't have the time. I'm going to highlight the fact that paclitaxel is well known to have different modes of action according to the dose and the tissue levels noted, at least in animal experiments. High dose paclitaxel is the oncologic application. It is very cytotoxic, and everybody knows about the mitotic arrest. On the contrary, low dose paclitaxel, it seems to be cytostatic. It seems to be driving aberrant multipolar divisions. It seems to be driving the creation of aneuploid daughter cells. And we do speculate that this may have to do something with some latent systemic cell-mediated adverse effects that we may be noting in human applications. This is the FDA summary of adverse events in general. And it is very, very interesting that it's not like we can note a single cluster of events, but across the board, with the exception of injury, which is a random event, across the board, pretty much any different kind of adverse event seems to be increased numerically in case of paclitaxel. And I have to say that this doesn't seem to be very, very reassuring. We have all seen those kind of images. This is a late pseudoaneurysm that has developed after application of a paclitaxel-coated balloon in the popliteal artery. This is one of our cases. We have also seen papers in the literature in case of paclitaxel-eluting stents. And this is the vessel wall edema on the left-hand side that is noted with the case of paclitaxel several months later, even if the stent is actually a very low dose paclitaxel stent. And when we do all those interesting contrast-enhanced MRI scans, you can see the diffuse vessel wall edema and inflammation even several months after paclitaxel has been, the paclitaxel-eluting stent has been implanted in the vessels. So I think that in conclusion, at least in our eyes, we see strength, we see consistency, we see temporality. The dose response element, there is some data there. And if anything, as a take-home message, I would highlight again the heterogeneity of what we call the mortality hazard in the case of paclitaxel-coated devices. Thank you very much, guys.
Thank you very much, Dr. Katsanos. Great, both very compelling presentations. Let's open it up to the panel for a discussion now for a few minutes and a chance everybody to ask questions to Dr. Katsanos and Dr. Parikh and give them an opportunity to say any rebuttals that are necessary. Anyone in the panel have any questions?
So, where you stand now, Dr. Katsanos, are you so strong on this that you would not think that the proven efficacy for limb-related issues would you put to the point where you're willing to kind of ignore that and say, I'm not using these in anybody? Is that what you're doing in your practice?
No. And from the very beginning, we have said this time and again, there is no, I think it is undisputed that paclitaxel is a very strong anti-stenotic medication with a well-proven drug effect in inhibiting neurogenic hyperplasia. However, I think we also feel very strongly that the very first generation of devices, either in the form of a paclitaxel routing stent or in the form of a paclitaxel-coated balloon, they did suffer from a number of local and perhaps systemic toxicity issues. This is where we stand. So we still prefer to use some low-dose paclitaxel routing stents, new generation devices. I personally think that new generation of paclitaxel-coated balloons will be also better engineered in terms of the drug delivery because the old ones suffer from a great deal of distal embolization of this, shall I say, very unstable medication. So we see a future, but not in the current form of most of the devices.
This is Parag Doshi. These are both great presentations. One of the things that has not been brought up in this discussion is the enormous cost associated with drug delivery platforms. So we're spending hundreds of millions of dollars. So on a global scale, it can be billions of dollars. And we're not discussed the total cost associated with the drug delivery platform versus bare metal or the regular balloon. And we don't know what is the impact on the health platform on that. Any comment on that?
I think there's a reason we don't use drug-eluting stents in the coronaries anymore. We have proven efficacy and safety, and we have a mortality reduction. The number of TLRs that are reduced will substantially reduce the cost to the healthcare system, specifically in the CLI patient population, but also in the claudicants who generally have a longer life expectancy. So I think that the calculus is much more complicated than the acute cost. I would, I guess, put a shot across the bow of those that would say that we can justify a difference in the OBL of a 1% penetration of drug-eluting products and a 40 to 50% penetration in the hospital setting. There's really no other explanation for that difference other than the cost, or rather the profit motive. And so, I think the clinical data and the guidance about TLR reduction were pretty solid. And I think we, as Dr. Katsanos and I both, I think we agree more or less that there are certain patient populations where there's probably good evidence that we can use these devices as long as we do it cautiously. And then there's some patient populations where we can be cautious and perhaps choose alternatives, accepting that we don't fully understand the data and the signal. But I think that the argument that we should save the healthcare system money by not using these devices is a flawed argument as well.
Quick question, Sahil, based on your last comment. So you think the current way we are treating the patients in two different settings is only the financial gains, and second one is going to be, you had some data regarding below-knee drug-eluting technology. Those are mainly related to the study centers, right? You don't have a...
Yeah, no, I think that's a fair point. No, so listen, I'm not castigating all OBLs, but we can't explain the difference in the penetration of drug-eluting technologies on just about any other clinical parameter. The only thing that is different is the cost. And I think that in the OBL, we can more efficiently take care of patients. I 100% agree with that. But it shouldn't be the case that we use different treatment strategies based on the venue of care. The standard of care should be the same. It's the venue of care that can be different and more efficient. With respect to the below knee segment, I agree that we don't have any FDA approved below knee drug coated balloons in the US. There are several under investigation. There's many limus agents and paclitaxel-eluting stents, as well as a forthcoming bioresorbable scaffold study here in the US. So I think the jury is out. We don't have any great products for the below knee segment, and we're still trying to figure this out. Yes, it's happening in study centers, but I can tell you, for example, the Saval trial has OBLs as well as hospital-based labs in the trial. So you can do high quality clinical investigation in the OBL. I have no doubt about that. It's really up to the investigators and the sponsors to have the guts to use those venues of care as we move forward.
And last and final point on all the studies, how long are we going to use this post-hoc analysis to convey the points that there is no difference? Because trying to do that sub-analysis, and it's a poor statistical method to look at the post-hoc analysis, which was not the intent of any of the studies, but we are using this to guide or prove the point that there is no difference between the two technologies, whether we are using drug-eluting technology or not. And most of the points are made based on the post-hoc analysis between the subgroup that there is no difference. And I don't see it as a good scientific evidence to say that there's no difference.
Well, I mean, the question is, there's no difference in terms of mortality, and then there's a difference in terms of efficacy. What hasn't been discussed enough is the risk-benefit calculus. What's the benefit? What are the risks? We're all talking about the risk appropriately, but I think that you're right. There's no prospective trial, but Nilesh, the estimates of the N of that trial is anywhere from 5 to 40,000 patients, which has been deemed untenable even by the FDA. And so, I mean, we have Eric and other trialists on the line. They might be able to tell you what the value of doing a DAPT-like trial is, but I know Eric is still smarting from his role in participating in the DAPT trial, in which we got an answer about coronary drug-eluting stents well after we were able to glean that answer from the other available data. And I think that's the point of trying to sum and subsume all of the data that are available globally. There's many thousand more patients in pending trials in which we'll get an answer far sooner than if we try to do a prospective trial. I'd let others comment.
Yeah, I would like Katsanos to comment on that, because as statistician, I think those are the lowest form of data where you start analyzing. They're good for postulation for the next study, but to come to a conclusion, which most of the journals do put in as a conclusive evidence that this is what the final answer should be, I don't buy it usually.
Well, we try. I think everybody tries to make the best of the data at hand. This is a very rapidly developing situation, in spite of what a lot of people think, because like Dr. Parikh explained, a number of studies are in progress. I mean, we have all become very smarter in trying to engage with data and understanding the data. And what I have personally, I would like to say is that there is what we call the most important bias. There's always bias. I mean, I've got bias, you've got bias, everybody has bias here, you know? And the most important bias when we try to interpret all of that is what we call, I think, spectrum bias. So spectrum bias means that at the very beginning, the first randomized studies are applied in a very sort of naive patient population in terms of risk factors. And the more we go on, those devices are applied in patients with a lot of comorbidities and a lot of risk factors, etc., etc. And this exactly explains the difference between, for example, the STELLAR-X outcomes and the other studies, because the STELLAR-X had a lot more risk patient population. You know what I mean, Sahil? And this is very important to understand as an investigator and also as the physician ourselves, because it is exactly the same discussion. If you are a patient with a number of risk factors who are competing and you're going to die in 30 to 50% of the time, if the risk of paclitaxel, let's say, is another 3%, it may make no difference. But if you are a young claudicant who can actually go and walk about your pain, then it makes a hell of a difference. So I think this is how I personally see this, and it's not a black and white thing, you know. It tends to drift from uncertainty to certainty, etc., etc. You know what I mean? It is what it is.
I have one more question. What's the current data on the in CLI patient rate of amputation in drug delivery platforms versus the non-drug delivery platforms?
So,
Yeah, the question was, is there a difference in mortality in CLI patients with the drug-eluting platform?
Not mortality, the rate of amputation, because we're trying to remove the amputation. So we talked about mortality, but what is the data or what's the advantage of drug delivery in amputation rate or the tissue?
yeah. So we published, this is why we published our second meta-analysis. Our second meta-analysis, very, very briefly, I will explain, used an endpoint of amputation-free survival because this is the recommended endpoint in CLI patients. But honestly, the individual components were not significantly different. However, it is very, very disturbing that whatever kind of endpoint you look at, it seems to be 1.3 to 1.4 times higher in case of paclitaxel. This is unfortunately a very disturbing numerical finding, you know. You look in the coronary, there is 30 to 40% something there. In the coronaries, again, drug-coated balloons compared to everolimus stents, they have higher mortality. In the legs, they have more amputation. So there is it significantly so? No, it isn't, but everything is drifting to a disturbing direction. And I think we need to be aware, and this has to be part of the discussion.
So should we just put a hold on drug delivery balloon until there is a large randomized trial of sufficient power of 10,000 people?
No, we have to be physicians. We have to interpret the data at hand. We have to continue to be investigators, and we have to be serious, you know? I mean, we discuss patient options. We still ask patients to go and walk about for like 3-6 months before they come for an angioplasty. We have to do the calculus, like Parikh said. I mean, it is a trade-off. Everything is a risk-benefit decision, you know. The same with COVID, the same with everything, you know. We shouldn't put. I'm personally, I like to see ourselves as investigators that are very, very responsible and very, very number aware. I don't like to put barriers, yeah?
Okay, well, thank you very much for this great debate. I think that we are quite over time. I know it's an extremely important topic and very charged topic today. So we can talk about this for some time, but I think that in the interest of the time, we'll have to move the session further. Let's now get into the therapeutic anticoagulation in COVID-19 patients to avoid a venous thromboembolism. It should be the standard of care. The pro side will be done today by Dr. Umberto Campia, who is the Assistant Professor of Medicine at Brigham and Women's Hospital in Massachusetts. Umberto, thank you very much. And the floor is all yours.
Thank you so much. First of all, am I sharing the right screen?
Yes.
Yes, perfect. Thank you so much. First of all, it's a great pleasure and it's an honor to be within this esteemed faculty. And also it's a pleasure because many of my colleagues are also good friends. And today I have the sort of great pleasure of debating with my good friend, Jeff Barnes, who is one of the most, I would say, skilled debaters. So I will do my best. But Jeff, I know it's going to be a fair sort of debate. And without further ado, I need to make a preamble, first of all. And I agree that the gold standard in evidence-based medicine is the randomized controlled trial. So we should not, unless it is absolutely necessary, reduce our sort of standards and lower our standards and not aim for the gold. And unfortunately, it's not always possible because randomized controlled trials require time. This is just, you know, slides from the Amplify trial in which apixaban as an anticoagulant was compared with standard anticoagulation. And we can see that it takes hundreds of days, to obtain adequately separating curves and to obtain statistical significance. So we are now in a COVID pandemic, and unfortunately, we do not have the luxury of time. And if we start looking at January 22nd, that's when the first confirmed case of COVID in the US was reported. And just after a few days, we can see that cases had been reported in other states, and there was just, at least at the beginning, a relatively small increase. But if we go just 12 days, and we can see that we've gone from 9 reported cases to 1,336. This is an increase of 148 times. And then if we move just another 20 days ahead, we go from 1,336 cases to over 203,000. This is another 151 times increase in cases. Things move very fast. And in April 30th, now we are at over 1 million cases. This is another 5 times increase. And therefore, we do not have the availability of data. However, there are data that have been reported initially from China, where there was a sort of the early epicenter, then from Italy, then from other countries in Europe, that suggested that there was a worrisome incidence of venous thromboembolic events in patients with COVID disease, particularly in patients who were critically ill. One of the first reports from China, from Wuhan, was from a retrospective analysis of an ICU data. And we can see that out of 81 patients, about 25%, 20 patients had a history of venous thromboembolism. Well, the paper, first of all, was very small. The data were very, I would say, limited. And the patients did not receive anticoagulation. It's not clear from the paper whether there was no therapeutic or prophylactic, but it's fair to assume, based on the pattern of approach in China, that these patients are not even prophylactically anticoagulated. But so we will say, okay, these patients are critically ill, they're not adequately anticoagulated. So what if the patients do receive anticoagulation? And so we can see that data from France, and these are data from 2 intensive care units, that prophylactic anticoagulation was administered in everybody. Was prophylactic anticoagulation, but in a number of patients, there was also therapeutic anticoagulation. And therapeutic anticoagulation was based on the decision of the physician on whether the patient had hypoxia or whether the patient had other concerning parameters that would increase the suspicion for a pulmonary embolism as the cause. And we can see that there was a 100% rate of venous thromboembolism, and this is not symptomatic. The patients underwent as a standard of care a venous ultrasound with compression, and therefore this was based on an active screening, not on just a symptomatic manifestation. And we can see that in patients who had received therapeutic anticoagulation, so that were the probably more critically ill, the ones that were more severely affected, that there was a incidence of about 33% of pulmonary embolism despite full anticoagulation. So the authors of the study remarked that using a systematic VT screening strategy, they found almost 70% incidence of venous thromboembolism in anticoagulated COVID-19 patients, and they suggest considering VTE screening and therapeutic calculation in severe COVID-19 patients. When we consider the previous cohorts, they were in the ICU. What about patients that are not as critically ill, that are in the hospital, but not in the ICU? And data from one of the large academic hospitals in Milan in northern Italy, which is one of the areas that had been hit the hardest in Europe, and especially early in the sort of west movement, the westbound movement of the epidemics, of the pandemics. And we can see that patients in the intensive care unit that are reported in this column had a much higher risk of thromboembolic events compared to the patients that were in the general ward, almost a 3 times higher risk. Interesting is also to notice that not only patients in the ICU had a higher risk of venous thromboembolic event, but also of arterial thromboembolic events or arterial thrombotic events, particularly ischemic stroke, acute coronary syndromes, or myocardial infarction. And again, there was approximately 2 to 3 times higher risk compared to patients who were on the floor. But what is the actual effect of COVID on the circulation? And we have important insights from the data from a recent autopsy study that compared patients that had died from influenza pneumonia versus patients that had died from COVID pneumonia. All of these patients had reported the presence of an inflammatory infiltrate, as it is expected. However, patients who had COVID-19 pneumonia had particularly striking findings of thrombosis in the small circulation in the lungs, and also they had some evidence of abnormal angiogenesis or capillarogenesis, and this suggests that the COVID-19 acts on the endothelial cells, and as we know, the endothelial cells are the main controllers of vascular function and of thrombosis and hemostasis. So COVID-19 appears to be a perfect storm for the occurrence of thrombotic events. Patients have risk factors for venous thromboembolism. They are acutely ill, they are bedridden, they have multiple invasive procedure, catheterizations, they have sepsis, they may be dehydrated, they may have their own comorbidities, and COVID adds a dramatic inflammatory response that can be seen in all a large number of hemostatic abnormalities, levels of D-dimers that are beyond the test range, but also fibrin degradation products, PT increases, and also platelets that may drop significantly and also may increase. So you have this wide range of effects. And this also has an impact, obviously, on clinical outcomes. So what should we do to prevent VTE in COVID-19? Obviously, the societies have done their best to give guidance to clinicians that have been fighting this battle in this particular in the ICU, and the International Society of Thrombosis and Hemostasis recommends the use of low molecular weight heparin in all patients, including those that are not critically ill who are admitted for COVID-19, obviously barred any contraindication. And the American Society of Hematology also has been very proactive and has a website that has a sort of question and answer type of guidance. And so the first question is, what is the recommended VTE prophylaxis in patients with COVID-19? And they recommend that all hospitalized adults with COVID-19 should receive pharmacologic thromboprophylaxis with low molecular weight heparin over unfractionated heparin in this to reduce contact, and unless the risk of bleeding outweighs the risk of thrombosis. Okay, very good. Now, should seriously ill COVID-19 patients receive therapeutic intensity anticoagulation empirically, meaning we don't have evidence, but should we anticoagulate? And they acknowledge that microvascular thrombosis is hypothesized to be involved in hypoxemic respiratory failure in some patients with COVID-19. Autopsy studies to date have been limited, but they do show large vessel microvascular thrombosis, pulmonary hemorrhage, and obviously high prevalence of VTE. Good. So they also say observational data should not be used to support changes in practice due to the presence of survivor bias, confounding by indication, lack of adjustment for important patient comorbidities and other treatments. And I completely endorse this approach. And they, however, also leave the open question, whether critically ill COVID-19 patients should receive therapeutic anticoagulation in the absence of confirmed or suspected VTE is unknown. So it's not the lack of evidence, is against the evidence that may be collected. So it's interesting though, because they have the next question: how should we manage COVID-19 patients who experience recurrent clotting of access devices despite prophylactic anticoagulation? And they say, although of unproven benefit, it may be reasonable to increase the intensity of anticoagulation from standard intensity to intermediate intensity prophylaxis, or from intermediate intensity to therapeutic intensity prophylaxis, to therapeutic intensity, or to switch anticoagulant in these settings. Any decision obviously should be based, it should take into account the individual patient bleeding risk. So it seems to me that there is a little bit of a double standard. No sort of therapeutic anticoagulation if the patient is critically ill, but if they are clotting, then we should consider that, even if it is an unproven benefit. So this is a very well done recent review of COVID and cardiovascular manifestation of COVID, and they have reported this sort of pyramid in which VTE prophylaxis should be considered in patients who have mild to moderate or severe COVID. However, I sort of posit that therapeutic intensity VTE prophylaxis may be considered if it is not contraindicated in patients with moderate severe COVID-19. So in conclusion, until we have evidence-based data from randomized controlled clinical trials, it is my opinion that in seriously ill COVID-19 patients, therapeutic anticoagulation may or should be the standard of care to reduce the risk of venous thromboembolism. And I thank you for your attention, and I'm looking forward to see what Jeff has in the store for this great debate. Thank you so much.
Thank you very much, Dr. Campia. Now I'd like to invite Dr. Geoffrey Barnes, who is Associate Professor of Medicine at the University of Michigan, who is going to speak about therapeutic anticoagulation in COVID-19 patients to avoid thromboembolism. We need more evidence before implementation. Thank you, Dr. Barnes.
Well, thank you so much for having me, and thank you especially to Umberto for really setting the stage. And I'm going to argue, Umberto, you made my job easy because you made all the points that I think are really important for us to discuss here. First, I do have disclosures, which include consulting with some of the companies that make the anticoagulants that are related to what we may be talking about. I agree with you, Umberto. COVID-19 is a prothrombotic condition. And in fact, I think venous thromboembolism is the #1 complication that's not directly related to the infection. It's the, the consequence of the infection. And it's something we have to wrap our brains around, and we have to figure out how to treat to help manage our patients. This is just one piece of data, and you showed a number of others. This is data from the Netherlands showing the risk of venous thromboembolism. And in this particular case series, they actually scanned all the patients for venous thromboembolism to try and identify who was having a clot. And you can see that there is a high incidence of VTE. That does seem to be associated with ICU stay. It's much more likely in our critically ill patients, seen by the red line on the right side of the screen. And also there's an element of D-dimer that can be a predictive variable in there. So clearly venous thromboembolism is a major risk consequence of COVID, and we need to do anything we can to try and prevent VTE from occurring. However, we have to remember that our strategies for preventing VTE are not without risk themselves. And so I just want to remind us what the risk of bleeding is when we give people different doses of anticoagulants. Now, from this one meta-analysis of 7,000 patients who received prophylactic doses of heparin, we can see that the risk of major bleeding is quite small. It's almost 0.5%, 0.6%. Yet if we look at a separate meta-analysis of patients who were receiving therapeutic doses of heparin, be it for an acute coronary syndrome or a venous thromboembolism event, you have much higher rates of major bleeding. In fact, in this particular meta-analysis, you had the same major bleeding rate of about 4.5%. I want to draw a contrast here between prophylactic dose and therapeutic dose anticoagulation. That is a greater than 7-fold increase risk of major bleeding. And major bleeding are things that require transfusions, things that require procedures to control, especially if somebody's already in the hospital. So not that there isn't a role for therapeutic anticoagulation, but we really have to be thoughtful about when we're going to use it, because it's not without risk. It has to be done quite carefully, and I think selectively, without clear evidence that the benefits are going to outweigh the risks. Now, why are we even talking about therapeutic anticoagulation for the purpose of VTE prevention? I think most of it comes from this study. It came out of Mount Sinai. This is a major hospital system in New York City. They looked at just shy of 3,000 patients who were hospitalized with COVID-19, and they compared the patients who received therapeutic or treatment dose anticoagulations to those who didn't. Either they received nothing or they probably mostly received a prophylactic dose. And on the left side of the screen, you see the overall cohort, and that line in blue, which is the therapeutic dose anticoagulation, does seem to have some slightly better survivability. But they really noticed the difference when they looked at the smaller group of patients who required mechanical ventilation. And in this case, they did see a bigger difference, and you can see the mean survival there was quite striking, at least graphically, when you look at it. And so this really, I think, got a lot of people thinking, and there were a number of press releases that came out to say, well, I would use therapeutic anticoagulation in my patients. But I think we need to hold up for just a minute. Let's look at the data in a little bit more detail. And I have a little bit of concern with the way this observational retrospective data is interpreted. The first is that there was no in-hospital mortality benefit across the entire population they looked at. 22.5% versus 22.8%. So on the whole, they didn't see a mortality benefit when they used therapeutic versus sub-therapeutic doses of anticoagulation. Second is, in the patients who got therapeutic anticoagulation, they were far more likely to be ventilated. Almost a third of those patients were on the ventilator compared to only 8% of patients with prophylactic. And the patients who received therapeutic anticoagulation had higher baseline abnormalities on a number of factors, their coagulation factors, their inflammatory factors, even the D-dimer. And so this really raises the issue that there's a lot of selection bias that's going on. Sicker patients were getting more intense therapies and therefore have opportunities for benefit, but potentially also at risk for bleeding. There may be other things going on here. So as we would see with any observational study, we always have to be concerned about selection bias and issues around unmeasured confounding. And I think those are certainly going to be the case here. However, there's one other piece that's really critical whenever we look at a medication study, especially one that's done observationally, and that's around this issue of immortal time bias. And if this is something you haven't heard about before, I think this graph down at the bottom right can really help to look at it. if you're going to classify patients into groups based on whether or not they received a drug or a therapy, but that drug or therapy doesn't start right at the same time as follow-up, there's a concern about potentially having an immortal time piece that goes in there. So in the blue bar that you see, if you start follow-up, let's say on the day that they're admitted, but they don't receive their prescription for a couple days afterwards, there's a period of time for which any patient classified in the treatment group has to survive because they had to survive long enough to get that treatment. Whereas if they had died beforehand, they would have then been assigned to the non-treatment group. They never would have had the chance to get a treatment. This is certainly something we have to consider in any observational study, especially drug therapy studies like this. And in this particular study, the median time between hospitalization and therapeutic anticoagulation was about 2 days, with a range of 0 to 5. So there certainly is the potential that there could be some bias related to the immortal time aspect. Now, of course, if we think therapeutic anticoagulation is beneficial, there's another group we could look at, which are people who had to be on therapeutic anticoagulation anyway. Maybe patients with atrial fibrillation or a mechanical valve or some other reason that they were taking therapeutic doses of anticoagulation before they even arrived. This was an analysis from the exact same health center in New York City, in the Mount Sinai system, looking at patients who were on anticoagulation before they arrived, that's the green line, versus patients who were not. And interestingly, you see no difference in survival and no difference in time to mechanical ventilation. So this idea that being on an anticoagulant, maybe in those early days of the infection before you arrived in the hospital, could that have helped to prevent the early formation of a DVT that could then embolize a few days later to cause a PE? We don't seem to see evidence here. Again, it's observational data. It's got certain issues, but it certainly raises some key questions. So Umberto, you actually pointed to the ISTH guidelines, and I want to thank you for doing that. There have been a number of society guidance documents that have come out, and I actually think they all support the position I'm arguing. ISTH said that a universal strategy with standard dose unfractionated or low molecular weight heparin in a non-ICU patient is the right way to go. And that a small portion, about 30% of their Delphi panel, said you could consider an intermediate dose if you wanted, but they're not saying go full bore with therapeutic anticoagulation across the board. We need data before we can support that. The Anticoagulation Forum had a similar guidance. I was a part of this one. We said standard dose prophylaxis for non-critically ill hospitalized patients. And even the most recent, the CHEST guidelines from the American College of Chest Physicians, they're coming out in favor of standard dose prophylaxis, which is preferred over intermediate or treatment doses. That's not to say you can't selectively use those higher doses, but it shouldn't be the standard of care for all patients with COVID-19 in our hospital. So I want to leave you with a few key take-homes that I think justify the position that we need more evidence before we implement therapeutic dose anticoagulation. The first is we know COVID-19 increases the risk for VTE. That's a given. I agree. We also agree that VTE prophylaxis is critical for all hospitalized patients with COVID-19. However, higher doses of anticoagulation lead to more bleeding, and we don't yet have data around efficacy. And that our observational studies are critical for raising questions, but we have to be careful not to overinterpret them. There's always potential for biases. Our guidelines are telling us to stick with the evidence-based strategies that we have and maybe think about those intermediate doses in the critically ill patients if we need. And last, and I think we would all agree with this, is we need to participate in clinical trials. This is a critical question on how we care for these patients. We will not know the answer until we have the clinical trial data. And so if you have any opportunity to participate, there's a number of them going on. I would strongly recommend that you do so. So I'll stop there and turn it back to you, Raj. Thanks so much.
Thank you very much, Dr. Barnes. There was both you and Umberto very well explained the subject. We have several questions from the audience, as well as we'd like to have a little bit of a panel discussion. I'll ask the first question here from the audience, from Dr. Cater, that should D-dimer or any other parameters be used to guide starting on anticoagulation and the dosages, especially given that imaging is a challenge in this patient?
Jack, I'll let you go to the first.
Yeah, thank you, Umberto. That's kind. You know, Raj, we do know that the D-dimer is predictive of poor outcomes. That's been shown not just from data from China, but also data from Europe and now even in North America. And so I think the opportunity to check a D-dimer to help with risk stratification makes a lot of sense. I am not advocating that you use a D-dimer to guide your anticoagulation prophylactic approach. Some centers are doing it, and I think that they are probably justified as long as they're measuring it. We don't have any prospective data to tell us what thresholds you should be using or whether the higher doses of anticoagulation are actually efficacious. So we are not doing it at my center. I think it's something you can check on admission to understand risk. It may be something to check prior to discharge if you're considering a post-hospital prophylactic course, but it's not something that we're necessarily using to guide prophylactic anticoagulation at my center, and most of the guidance documents out don't necessarily recommend that either.
Any other panel members have any comments or questions?
Raj, I have one comment. We actually will give the example of the anecdote that happened. One of our cath lab nurses had COVID, and he was not hospitalized. He had a pretty significant episode, stayed home, had a long period of isolation, and came back. And he actually worked with me in the cath lab the first day. He was a little tired, but did okay. And then in the afternoon, he got short of breath, and we sent him to emergency room, and he had a pulmonary embolism. And this is after he had recovered. So do you have any comment of post-recovery thromboembolic events and whether there should be Xarelto, Eliquis, or anything, maybe in any particular group?
Yeah, I think this is, it's a really good question, right? Like, what do we do with patients after they leave the hospital or as they're recovering? And I think many of us have anecdotes of patients we've seen who've come back with a PE. I've certainly seen a few where their PE was their presenting symptom, and then we found out that they had COVID. We don't have any data on that post-hospital course. What's the risk after hospitalization, or what's the risk in sort of the ambulatory patients who've never been admitted to the hospital? So it's definitely a data-free zone. We know from the pre-COVID era that there is evidence to support either rivaroxaban or betrixaban in a post-hospital VTE prophylaxis regimen, and those are both FDA-approved strategies. It's reasonable to think about that in the COVID situation, but I just don't have any data to guide us. We need some post-hospital data to really help answer that question better.
Yeah, absolutely.
Go ahead.
No, so, and also the American Society of Hematology does raise that one of the question is, should we consider prophylaxis? And I think that patients, based on the results of the sort of post-discharge critically ill patients, such as the APEX trial, we do consider discharging patients with appropriate prophylaxis.
Okay, Dr. Constantinides wants to say something.
No, I wanted to say, I mean, this was really a very great exchange of thoughts. And I would also advocate a lot of caution when we interpret those data that say that such a huge number of, let's say, 70% of patients, I mean, this was one set that of data that was mentioned by Dr. Campi. I mean, there are other data indicating that the risk is about 25%, perhaps 30%. And I would also like to emphasize the fact that in the Italian study from Milan that you cited, I mean, about 50% of these patients appear to have the thrombotic complication upon admission, which of course may say why, of course, in these patients, therapeutic doses may be necessary, but this will not be thromboprophylaxis. And there is no other situation in acute medicine or even in the worst types of cancer in which, for ambulatory patients, but in acute medicine for patients who are hospitalized, that we routinely need therapeutic anticoagulation for thromboprophylaxis. So I think it is quite wise to be to ask for data here. And of course, there may be some situations, as you said, with the thrombosed catheters, but generally, I think it is wise to say that the data we have available at this time do not advocate routine therapeutic dose thromboprophylaxis.
Okay, at least there is one vote for not routine. Dr. Kabnik?
Thank you very much. I really appreciated both lectures, and I've heard a few of these before, but there was no mention of antiplatelet drugs. Is there a role for antiplatelet drugs?
I think that's a really good question. And, if you go back to most of the other VTE literature, you'll find that antiplatelet drugs, especially aspirin, there is some evidence that it may be beneficial in sort of long-term secondary prevention. We actually had two reasonably large studies that looked at that and pooled their analysis. However, they are far less effective than anticoagulation, and they're not routinely used in a hospitalized patient outside of the post-ortho population. That's really the one place where I do think they're showing some evidence. So I don't think they would be a strategy to use in and of themselves. Whether there'd be any benefit of adding aspirin, let's say, low-dose aspirin to a prophylactic regimen of heparin or unfractionated heparin. It's a really interesting question. I would not do that outside of the context of a clinical trial, but it's certainly something that's worth exploring.
Thank you.
Great.
Raj, one last comment regarding this need for anticoagulation. We reviewed our data from one hospital where we had 800 patients. The issues that we face in clinical world is which patients would benefit from anticoagulation, and the incidence that we found within this group of 800 patients that were admitted to the hospital with COVID. We had about 27 or 30 patients that had real significant finding of thrombosis with PAD or pulmonary embolism. And they all had D dimers that are elevated, which is a common finding in all COVID patients. And out of all those patients, most of them ended up needing amputation or they died. So mortality rate on this sick patient who develops thromboembolism is very high. And trying to figure out which are the patients that you would recommend anticoagulation is really a tough challenge. And our review did not come up with a good answer as to which patients would benefit, whether we should have a universal policy that anybody with D dimer that are elevated should be anticoagulated or not. So I think it's a data-free zone. I agree with you. And individual decisions based on the resources, because with COVID patients, trying to get ultrasound is, again, exposure risk to a whole bunch of people that are involved in doing the studies is a huge risk. So as of now, we had a policy where we would recommend anticoagulation on patients with high D dimers and having an evidence of PVD to prevent a major thromboembolic episode. The DVT was still a questionable concerns whether we would put all of them, but PAD, we did put them on anticoagulation, or at least wherever we were consulted, we recommended anticoagulation till they recover from the COVID crisis and then deal with it at later date.
Okay, thank you very much, Nilesh. For the interest of time, we're gonna have to keep moving. Let's now move to the third debate, another very important subject on massive pulmonary embolism. The first line treatment should be mechanical embolectomy or catheter-directed thrombolysis. To do the pro side, we have Dr. Jay Geary, who is Director of Peripheral Intervention at the University of Pennsylvania in Philadelphia. And thank you, Jay, for taking the time, and the floor is off to you now.
Thank you so much. I'm going to go ahead and talk about using invasive approaches first for massive pulmonary embolism. And it's an honor to debate against Dr. Constantinides, who, in my view, is the most impactful person worldwide in the study of inpatients with pulmonary embolism. My disclosures are here. The top half are relevant to the talk. So the main focus of our talk today is going to be regarding massive or so-called high-risk PE. So these are patients who present to your hospital and actually have ongoing shock or hypotension or cardiac arrest. So this is really the highest of high-risk patients who present with PE. On this figure, they represent the top of the scale. They represent roughly 5% of all patients in America who present, and they have very high mortality rates. Traditionally, the major treatment for these patients that's been recommended in guidelines has been systemic thrombolysis. That's been the mainstay of therapy. The unfortunate issue, though, is that current massive PE treatment paradigms that are largely based upon systemic thrombolysis, frankly, don't work well. This is an in preparation meta-analysis by a group I'm working with, and we're finding 22.5% in-hospital mortalities with current approaches. A variety of observational studies that follow people out to 30 to 90 days have seen mortalities in the 30 to 60% range in this population. So from a mortality perspective, a treatment structure that's based primarily on systemic thrombolysis is just not getting it done. I view this as an unacceptable mortality for what really is a preventable death in a patient who's coming in with acute PE. In addition to concerns about mortality, there are many other concerns with systemic thrombolysis. This is from a meta-analysis from our group from years ago, where we looked at all randomized trials of systemic thrombolysis in the literature. And in this meta-analysis, we were able to find that rates of major bleeding in the group who received thrombolysis were 9%, and rates of intracranial hemorrhage were 1.5%. It's important to note that in this meta-analysis, over 80% of patients we studied were actually intermediate risk, not massive PE patients. In massive PE, the rates of these complications are even higher. And observational data indicates major bleeding rates of over 10% and ICH rates of over 3%. So you're looking at a therapy that largely is not effective enough to prevent mortality and is associated with some significant complications of bleeding, most notably ICH. So the question becomes, where did this guidelines come from and what are they based on that is telling us to use systemic lysis in massive PE? Well, you're going to see here, it's based on a randomized controlled trial published in 1995 that was a positive trial for systemic thrombolysis in patients coming in with massive PE and hypotension. Sounds good. Sounds like randomized data means that this should be how we're doing things. But there's a catch. There were 8 patients in this trial. So it is not realistic, in my view, to base our treatment paradigms completely on a single study of 8 patients, even if it was randomized. So I would argue that data in this circumstance for systemic thrombolysis in massive PE is weak, regardless of what guidelines say. This is very weak evidence. So what I'm arguing for is that this group of high-risk PE patients has a very high mortality, so we should be taking a very different approach. And I'm asking for folks to think about having a paradigm shift in the management of these patients. The first question I ask myself when I see these patients in my hospital is, should I institute emergent mechanical circulatory support? And how do I decide whether to do that? Or I ask 3 questions. First, does the patient have life-threatening comorbid? So if this is a stage 4 cancer patient, perhaps this is not the appropriate patient for emergent mechanical circulatory support because they may not have a long lifespan anyway. Are they a reasonable age? We tend to use 75 to 80 in our hospital, although I have gone above this age in some cases, patients who truly didn't have any other comorbids. And lastly, is this patient experiencing escalating pressor use, or actually did they have an in-hospital cardiac arrest in front of my eyes and having ongoing resuscitation attempts? The reason for this is there are some of the massive PE is a spectrum, and there are some of these patients who actually are on the lower end of massive PE who may just be on a single pressor at a low dose. They certainly are very sick and at risk of decompensating, but they may not at that moment need true emergent mechanical circulatory support. But in those patients who you're starting your second pressor on, or God forbid, have an in-hospital arrest, if you have the capability, asking oneself whether they can institute emergent mechanical circulatory support to stabilize the situation, I think is a first question that should be asked. And ECMO is the most commonly utilized support strategy in these cases. And usually it's VA ECMO, or cannula, inflow cannula in the venous side, and outflow cannula to the arterial system. And this is because patients generally are in shock and they need both, they might need ventilator support, but they most importantly need cardiac output support from VA ECMO. My friend Ido Weinberg, pictured here, examined this in a population of patients at MGH in eras where there was a 24-hour ECMO availability from 2007 to 14, and an era 8 years prior where there was not. And as you can see, they had some very striking results we had in the study, where these were the sickest of sick patients on multiple pressors or having arrests, and they had 83% mortality at 30 days in the pre-ECMO era. And that survival rose to over 42%. So mortality is down to 59% in the ECMO era. It's observational data. It's not perfect, but it's giving you a signal that this availability of being able to save these very sick patients by supporting them is an important tool in our armamentarium. Additionally, it's important to recognize that perhaps isolated right ventricular support may have an option, maybe an approach in some of these patients, and may avoid some of the vascular complications associated with arterial access with ECMO. And this is because these patients' RV is failing. So if they have an intact LV, perhaps supporting the RV alone on the venous side could work. And my friend Mahir Elder in Detroit has published on this. This is a strategy that he's utilizing in massive PE patients in one hospital where we does not have ECMO support. But he's been able to get these patients to the cath lab and place an Impella RP. In the first 5 patients that he published on, actually all 5 patients with massive PE survived with this strategy and adjunctive therapies. In this case, catheter-directed lysis used in all these patients. So that's what I'm arguing for, is to use ECMO in the sickest patients as a bridge to definitive therapy, which can be catheter-directed lysis, embolectomy with catheters, even bridging to surgical embolectomy, or in some cases, even anticoagulation alone, which I've used on a couple of patients who, for example, were post-spine surgery. I was able to manage on ECMO for 4 to 5 days and then decannulate them because they were poor candidates for a lot of other options. What are your options as a bridge, whether you're using ECMO or whether you have a slightly more stable patient with massive PE? Well, you have catheter-directed lysis options, and you have these 3 commonly used catheters with their characteristics noted here. This is largely placement of 2 5 French catheters via venous access from the femoral veins, the basilic or antecubital veins, or the IJs. And then having lytics dripped in over a course of anywhere from 4 to 24 hours at relatively low rates that are much lower than the rates than the doses that have been used in systemic thrombolytic trials. We recently meta-analyzed what the rates of major bleeding and intracranial hemorrhage are with catheter-directed lysis in prospective studies. There have been 6 prospective studies studying 556 total patients with catheter-directed lysis. And we found that major bleeding rates were about 4%. So you might remember I presented data that said that these rates look like 9% in prospective randomized trials of systemic lytics. And intracranial hemorrhage rates we had at 0.7%. And you might remember that in those randomized studies, we're seeing intracranial hemorrhage rates around 1.5%. So this is not a randomized apples to apples comparison of catheter-directed lysis versus systemic lytics. However, the currently available data suggests lower bleeding rates with catheter-directed lysis than with systemic lysis. Another option involves use of embolectomy. The most popularly used embolectomy device in massive PE patients currently in America is the FlowTriever device, which does have a labeled FDA clearance for PE in general. This is most commonly, these cases are most commonly performed with either a 20 or 24 French sheath being placed in the right common femoral vein, a large aspiration catheter being taken up into the clot, and then aggressive large bore aspiration being performed of clot like you're seeing here. There are adjunctive mechanical embolectomy that can also be deployed, although that is being used in a minority of cases in adjunct. Usually this is being used primarily as a large bore aspiration catheter that creates pretty aggressive aspiration due to how large these catheters are and a technique that has been used for how the aspiration is performed with this device. So one question you're going to ask is, Jay, why don't I just go ahead and give systemic lytics, see how they do, and then escalate my care afterwards if I need to? Sounds reasonable, but keep in mind there could be a price to pay with this. When you give systemic lytics, you make, for example, support with ECMO much more difficult afterwards, because these patients now are at dramatically increased risk if you're going to use large bore access afterwards. In the one paper that's in the literature that kind of looked at this from friends at Kentucky, they found that all 5 patients receiving systemic thrombolysis prior to ECMO died. It certainly has been our anecdotal experience that placement of patients with PE on ECMO after systemic thrombolysis has been something that's associated with quite an increase in complications from a vascular standpoint from the ECMO. And finally, I talked a lot about ECMO, but like I mentioned, there are a number of patients who don't quite need ECMO, although they certainly are sick and are on pressors. These are kind of your quote unquote stable massive PE patients. They're kind of tipped over from intermediate risk to high risk. I would argue that taking these patients to the cath lab while they still are in that stable state puts you in a nice controlled situation to make some decisions. You can have mechanical circulatory support on standby, either isolated RV support or full-on ECMO, because you're in a setting where you can place these in the safest way. And then you can then choose between catheter-directed lysis, which I mentioned may have lower bleeding risk than systemic lysis, catheter-based embolectomy, like with the FlowTriever. And you can base these decisions on the patient's bleeding risk, your own experience with the devices, and the patient's unique anatomical considerations of where this clot is located. So this is what I would argue is a paradigm shift that we should undergo if we really want to make the biggest dent in saving the most patients' lives who are acutely hospitalized with PE. Thank you.
Thank you very much, Jay. Now I'd like to invite Dr. Stavros Konstantinidis, who is a professor of clinical trials and deputy scientific director of Center for Thrombosis and Hemostasis at University of Mainz in Germany, who will now take the con-side. Massive pulmonary embolism, first-line treatment should be IV and systemic thrombolysis. Stavros.
Thank you. I will share my screen. I hope that will work. Is that okay? Everyone see me?
We see you. We see your
Thank
screen.
you. Thank you very much. So thank you very much for the invitation and for the opportunity to participate in this great panel with such important issues. And I'm really very happy because I could listen to a great talk by Dr. Geary, who really set the stage perhaps for the future of what the treatment should, I would not say should be, but should become for acute massive PE. And what I will try to do now over the in the next 10 minutes or so is tell you a little bit from, let's say, from a more methodological point of view, where we are today and where we can base our decisions upon today. So these are my disclosures in general. I've worked in several trials with thrombolytic therapy. So when we talk about what should be first-line treatment in an acute situation in generally, what do we mean? So it should work in everyone and everywhere. It should be a standardized method and depend as little as possible on the operator because we have no time to lose. It should be, one should be able to institute it promptly and it should work fast. It should be safe, broadly available, affordable, and it should be backed by solid scientific and clinical evidence. And I would like to review a few of these things on thrombolysis and show where the weaknesses are, where the strengths are, and what can be the situation today. This is so a little bit the European perspective of acute PE. You know, we talk about not massive in order to not to have it to create confusion with a large clot, but we talk about high risk, but it's more or less the same thing as the hemodynamic instability. And then we have the submassive PE, which I would very briefly at the end go into. And then we have, of course, the low risk PE, which is not our topic today. Now, let's talk about the massive PE, and that it was really great to hear from Dr. Geary, not just about where catheters can work, but of course about the supportive measures for the circulation, which are a very important aspect, and I fully agree. I mean, there are certain situations or certain manifestations of hemodynamic instability in massive PE. This is again from the ESC guidelines on PE that were published last year, and talk about patients who come in with need for cardiopulmonary resuscitation, patients with cardiogenic, or what we call today obstructive shock, and the other more classical old definition of persistent hypotension of at least 15 minutes. Now, in this situation, it's important to act as fast as possible. So what we have here is, for example, the algorithm that was repeated a couple of times in the guidelines, showing that you have to get to the diagnosis of acute massive PE first as fast as possible. And even if a CTPA is not directly available or feasible in that situation, you can rely on echo findings in the patient who is unstable. And we were just talking in the panel before the beginning of this session that the current COVID-19 situation is a typical situation where you may not even have CTPA, and even less so interventional measures available at all times. So if we come to high risk or massive PE, then it is clear that as soon as we diagnose this, be it with CTPA, which is the standard, or with bedside echo sometimes, then we have to move fast. And it is where we all agree that generally, although as Jay said very nicely, sometimes even anticoagulation may help, but generally we need some kind of reperfusion treatment. So what will be the reperfusion treatment? There are several meta-analyses on thrombolysis. That was a very nice paper by Chatterjee. I took this analysis, meta-analysis that we did in 2015, because we did not include catheter-directed methods. And so this is the plot for total mortality. And generally it appears from randomized trials that total mortality, if we take all the trials ever performed, the total mortality was reduced, well, by about 40%. And as you can see, this reaches hemodynamic significance in the bottom. The fact that thrombolysis works, or fibrinolysis works, hemodynamically and pathophysiologically, it is a fact. It has been shown for about 30 years. So this is not the problem. The problem is, what is the clinical benefit versus risk? And Jay pointed out very correctly that, of course, if we take now only the studies that included high risk or massive PE, then of course the situation is really quite poor. And you very nicely showed that the study in Mexico included 4 versus 4 patients, and the other studies were not much bigger either. And there were some studies of intermediate risk PE, so let's say a dark orange category, so they might be somewhere in that let's say in the border between the red and the yellow zone, but overall, of course, the effects are diluted, and we cannot definitely prove that there was a clinical benefit in patients who were in shock or who were hemodynamically unstable. But I would like, of course, to remind you that we cannot prove it for almost any intervention in medical intensive care in such situations, because it's very difficult to randomize such patients. So, and if we take all from this meta-analysis, other outcomes as well, not just mortality, generally, as you see, it appears studies that included, not exclusively those high-risk patients, but also included those patients in their population, that they generally show favorable clinical results. That's the meta-analysis. Of course, there is a problem, because this is a study, this is a meta-analysis, like all meta-analyses, which are, let's say, which have a large weight of the Pytho trial, which had more than 1,000 patients, which is a very large population for such a clinical setting. So they are dominated by that population. But so clinically, however, generally thrombolysis works. It does work pathophysiologically. It has worked hemodynamically. This has been shown for many years. It does work clinically, but of course we have not shown that it works in the shock situation. And of course there is now the huge problem of bleeding, which my opponent very nicely alluded to, and I think there's no doubt that there is clearly an increase both in major bleeding and in fatal or intracranial hemorrhage. So there are contraindications to thrombolysis. But of course, in this emergency situation, and when you're in a hospital where you cannot immediately make the choice of taking the patient to a cath lab to do a percutaneous catheter-directed approach, then in this situation of hemodynamic instability, most contraindications would be relative, as you can see. I mean, those here in the first part and the upper part of the table. So one would say that in this situation of massive PE, what we have today is, I have shown no publications, but I think we would agree that thrombolysis does work in everyone and everywhere, not just in a major academic tertiary hospital, but it could work in every community hospital. It could be available there. It is standardized, it's easy to use. It does not depend on the skill and the experience of the individual operator. It can be instituted promptly. It works fast. It alleviates pulmonary hypertension and right ventricular pressure overload within the first 2 hours, shown already in the 1990s. It is not very safe, there's no question. But it is broadly available and affordable, and the scientific and clinical evidence is moderate, is not very good, it's not satisfactory, but it is, as I said, not satisfactory for almost any intervention in this acute stage. So that's not very helpful. And this is why in the guidelines, what we did from the European part was to put thrombolytic therapy as first-line treatment, but of course say that surgical pulmonary embolectomy and interventional treatment, catheter-directed treatment, is the alternative if thrombolysis is contraindicated, if there is a high bleeding risk or has failed, and of course provided that there is the expertise and the resources on site. For 2 minutes, a couple of words on submassive PE, which sometimes may be very close to the massive situation, very nicely described as those stable massive patients, if you would like to put it like that. There, of course, the situation is more difficult because there we have the large PYTHO trial that is more or less an argument against lysis. We did have there a problem, we did have there a problem of safety. There were strokes, hemorrhagic strokes, more than 2% in this situation. And that was, of course, quite that was really a lot of hemorrhagic complications which are unacceptable because the intermediate risk or submassive risk population had an overall death rate of about 2 or 2.5%. And of course, you cannot risk a 2% hemorrhagic stroke in these patients. And there was indeed no subgroup that could be identified as benefiting or as being safer for thrombolysis compared to another. And there are also, and you know that unfortunately, no reliable, helpful thrombolysis bleeding scores to triage the patients and say, this is a candidate for thrombolysis and this is not. I mean, this is a very nice effort by Chatterjee and colleagues 3 years ago. And of course, actually, previous cerebrovascular accident appears to be the factor predisposing to bleeding, but we also knew that without a score. So again, so here in that situation, primary thrombolysis is a phase 3, a class 3 indication. That means it is not recommended and it can be done only. And in that case, of course, the alternatives are the catheter-directed methods if the patient decompensates secondarily. There, we do not have a favorable benefit to risk ratio. So in those patients who appear or still appear safe, appear stable, of course, the safety risks outweigh the potential benefits, and solid evidence in that case exists actually against lysis. So this is how we do it. This is how the situation is today. And this is how we try to help thrombolysis, which is not a beautiful method, but it is a method, as I said, which is broadly available to become perhaps safer, perhaps in the submassive situation. And this is what can be perhaps done with half those thrombolytic studies. There is suggestion by some small trials, this is a meta-analysis, that it might work with less or fewer bleeding complications. There's also the work by Dr. Sharifi that has been extensively cited, showing that half those lysis might help also over the long term. And this is something that is being done in the this is a study that is beginning, an academic study in Europe right now with half-dose lysis in this dark orange category. So in patients who are with submassive PE, they still appear stable, but they are very close to the stable massive PE situations that Dr. Gary pointed out. So I would say that thrombolysis is not a beautiful treatment, is not very popular. I would argue that mortality, however, in the United States and in Europe for massive PE appears to still to be so high, not because lysis is done and fails, but because people do not do it. People just anticoagulate. And then, of course, they might give lysis in the last moments. I mean, when there's nothing else to be done, and when patients die anyway. So there is a problem with the selection of these populations in real world data. And that at the end of the day, in order to say what can be now the first line treatment, we should always remember those arguments that should be the treatment that we can give immediately, that can work in everyone and everywhere, that should be standardized, not depend so much on the operator so that things can move as fast as possible, and it should be broadly available and affordable. And safety is an issue, especially in specific patients. So if we have many choices on site and we have a hospital that of course can afford and can offer alternative means, then it's great. But real life tells us that often we do not have everyone waiting for the massive PE in the cath lab, and these things may take more time. So thrombolysis still remains a tool that can help us fast in such an acute situation, at least for the time being. Thank you.
Thank you very much, Dr. Konstantinidis and Jay. Both did a great job. We're a little bit behind time, so we'll just have a discussion for only a few minutes. Any panel members have any comments?
This was wonderful. This is great. Jay, I just wanted to sort of get your thoughts on some of these things. I think clinically, as you know, a lot of us have moved towards using ECMO and mechanical thrombectomy, given that systemic lysis is a concern with the bleeding risk. One of the things that, sort of looking more into it and doing more of this, we recognize that the problem with ECMO is also, you also have a high rate of bleeding associated with ECMO, and there's a high rate of stroke, including intracranial hemorrhages that we have to take into account, especially when you look at registry data. Of course, this is not looking at PE patients, unfortunately. All this data is cardiogenic shock or pulmonary pathology and things like that. So that certainly has always made us a little bit more concerned in terms of using ECMO, in addition to the sort of the criteria that you had sort of presented in these scenarios. The other thing was clinically, a lot of our patients can be obese or moderately obese. So if you have somebody who's in an acute cardiac arrest situation in whom you haven't been able to obtain ROSC, trying to get the catheters in for ECMO and running it may take up to 40 to 50 minutes sometimes. And that might be vital time potentially that may not be sufficient if you have somebody who has a neurological injury for that period of time. So even if you get the ECMO ongoing 40, 50 minutes later, that may not lead to any neurological improvement down the road. And so this is sort of scenarios we've come across. Of course, systemic lysis also in an acute cardiac arrest situation has its own issues, but was just kind of wondering what your thoughts or comments were on this.
Yeah, I think that one of the key issues related to massive PE patients is that when they first enter the ER, all relevant parties in your hospital who might possibly be able to be involved in rescuing this patient are involved with decision-making early in their management. And I extend that, honestly, in our hospital, and this is part of this kind of PERT movement out there, to an extent, even to the intermediate risk population, and that it doesn't necessarily mean that 10 different people have to be told about every intermediate risk patient that comes in the door. But at least if one person who is familiar with taking care of pulmonary embolism, who is a consultant with expertise in that, is informed that there's an intermediate risk patient here, that person now can have a schema in his or her mind of what are their rubrics for escalation of care. I find that the majority of patients that have decompensated, who are patients who are not actively, I'm talking about the patients who are not actively arresting, But in those patients who are not actively arresting, there often are windows of times, often of hours, 1 hour, 2 hour, 4 hours, 8 hours, where they're in the hospital. And almost always you can go back and look, and often they're mismanaged, not diagnosed properly, not risk stratified properly, often not even anticoagulated therapeutically during that time. And that's all associated with their decompensation. If you can get earlier input from somebody who's interested in this disease up front, then those issues regarding ECMO can be avoided, in the sense that if a patient escalates to a certain level, where in my mind it's that second pressure being started, now that patient's being started on ECMO in a much more stable situation, not in an arrest situation. And you also have those windows of time to transfer patients to cath labs, where a lot of these things can be done a lot more safely with proper ultrasonographic and fluoroscopic guidance, which by experts in vascular access, which probably would dramatically reduce your complications as well. I think I think I look at just the system of care has to change for these patients.
That's great. Anyone else? Okay. All right. So let's keep moving. Another very important and a very subject that applies to a lot of interventionalists, and that is going to be antithrombotics and antiplatelet therapy post-peripheral vascular intervention. DAPT is sufficient in most cases. That will be the proposition that was going to be presented by Eric Systemski, who is a director of vascular intervention at Beth Israel Deaconess Medical Center. He's also director for vascular research and assistant professor of medicine at Harvard Medical School. Welcome, Eric. Thank you very much for taking the time to be with us. And you are going to talk about DAPT is sufficient.
Great. Thanks, Raj. Can you hear me okay?
We hear you great.
Perfect. Okay, well, wonderful. Well, thank you very much for the invitation to speak today and the opportunity to speak on something outside of paclitaxel, which I haven't had the chance really to do in the last year. So this was a nice opportunity. Let me move forward here. These are my disclosures. I want to point out I was on an advisory board for Janssen on the Voyager trial recently. Nothing I share here was discussed during that meeting. I also am an avid prescriber of low-dose Xarelto as part of the COMPASS trial. So I have some preconceived notions here, but I did not want to pass up on the opportunity to debate my good friend Mark Banaka and point out some of the holes in the Voyager trial. So I'll try to do that now. So just to review, and I'm going to focus here on the data that shows clopidogrel or not clopidogrel. So just a reminder, Voyager randomized patients to low-dose rivaroxaban 2.5 milligrams twice a day versus placebo after endovascular intervention or bypass surgery. You had to receive your first dose within 10 days of your therapy. And clopidogrel was allowed to be used as seen needed by the operators enrolling in the trial. So it was about 50-50 about who got clopidogrel in addition to aspirin and rivaroxaban, and about 50% who did not get clopidogrel. And in either group, we saw that there was an improvement in the endpoint, and this is through a little over 1,000 days, if you received rivaroxaban in addition to either aspirin or aspirin with Plavix. However, there was a substantial more amount of bleeding, particularly among those who got triple therapy, Plavix, aspirin, and rivaroxaban. So this is just the setup for what I'm going to discuss now. Now, we're interventional community for the most part, and I think it's a little bit cleaner to discuss the peripheral vascular intervention space, the endo. So I'm going to really focus on that. And I kind of split up this talk and debate about two issues. One is the device and procedure safety. So really focusing on what happens in the month or two after you do your endovascular intervention. And the second part is really the global cardiovascular event reduction. What happens, how does your therapy reduce your global risk over time? So moving first to the device procedure safety. So I'm gonna argue first up that this is not a new kind of debate. We've already looked at anticoagulation and endovascular therapy. When angioplasty was being developed in the 80s, this was kind of the first line therapy for trying to reduce re-occlusion after angioplasty. And again, remember, coronary and peripheral angioplasty was being developed in concurrence. Coronary kind of took the lead. And so we've had to extrapolate data from the coronary literature, but remind ourselves it's in some ways a similar bed, and some of these data do apply. So Coumadin and aspirin was the mainstay therapy for after coronary angioplasty. This is a trial in the 1984 that demonstrated, however, that Coumadin really was not more effective than aspirin alone for preventing reocclusion. And that wasn't a single study. There were multiple studies on this, and people started to change their mind about the role of anticoagulation to prevent post-procedure events. And that started the discussion about antiplatelet therapy. Here was an early study looking at dipyridamole in addition to aspirin, and showing that that was more effective at reducing post-coronary thrombosis rates. We also know the grave risk of bleeding that we see with full-dose anticoagulation in particular, and there's a lot of vascular events, bleeding events that are occurring at this time. Fast forward 10 years, and we've really refocused our attention now on the stent era, and this is really the first trial that demonstrated that anticoagulation was not effective for reducing stent thrombosis early after stent placement. This was the first of many ICAR trials. And as we can see here, they randomized patients to ticlopidine and aspirin versus a Coumadin alternative in aspirin. And both cardiac events and non-cardiac events were reduced with antiplatelet therapy. This changed the game for endovascular intervention and really started the era of antiplatelet therapy, in particular dual antiplatelet therapy, to prevent coronary events. Moving forward, we saw Marty Leon and some of my partners at Beth Israel's trial in the late 90s. And again, this looked at aspirin, aspirin and warfarin, and aspirin and ticlopidine. And again, there was a substantial reduction in events with the dual antiplatelet therapy arm. And really across all event points, death, revascularization, and thrombosis, we saw improvement with dual antiplatelet therapy. So a lot to learn here. More recently, as a postdoc, I was involved in the Deates study with Laura Mori and colleagues. We looked at 12 versus 30 months of dual antiplatelet therapy after drug-eluting stents. And dual antiplatelet therapy demonstrated sustained benefit for preventing stent-related events through 33 months of follow-up. And not only that, it reduced major cardiovascular and cerebrovascular events. So there's clear precedence for using dual antiplatelet therapy after endovascular intervention here in the coronary vascular bed. Now, I will admit there is not a lot of strong data for use of dual antiplatelet therapy after peripheral vascular intervention in particular. And that's just the gaps in literature here. So this is a meta-analysis by the Cochrane group that was performed in 2012. And there was an abysmal 2 studies that they could use to look at DAPT versus placebo. And you can see the effect estimate is on the right, the favored side of the line of equality here, the 1, but still didn't meet statistical significance. And when you compare that to Coumadin or vitamin K antagonist, again, it's still favoring DAPT, but did not meet statistical significance. These were small studies. And when you looked at DAPT versus a vitamin K antagonist with clopidogrel this time, this is a Chinese study more contemporarily. Again, the effect estimate favoring clopidogrel for patency, however, didn't meet statistical significance. There was one randomized trial to date that we all are familiar with called the MIRROR trial that actually randomized DAPT after peripheral vascular intervention, primarily involving the femoral popliteal artery. In this trial, you got 6 months of clopidogrel in addition to aspirin versus aspirin alone. And what the authors found was that there was lower target lesion revascularization at 6 months with with clopidogrel plus aspirin versus aspirin alone. However, as the trial mandated, you stopped clopidogrel at 6 months, and then there was kind of a re-narrowing of the difference. So there was no significant difference at 12 months as people rebounded from being off of clopidogrel. And there was even some suggestion of a mortality benefit here, but actually, unfortunately, did not meet statistical significance, very small sample size again. So this is the best data we have that showed that 6 months of DAPT reduced target lesion revascularization rates compared to aspirin alone. So why is it obligatory to use DAPT after PVI? Why am I taking that stance? Well, I think there's also precedence here. If you look at every major randomized peripheral trial that's happened over the last decade and a half, every one of these require dual antiplatelet therapy as part of their study protocol. Now, I know my friend Mark Banaka is going to say that's not reason to do it, but the horse is out of the chute here. We have to respect how we're doing these trials. This is across devices, atherectomy, POBA, BMS, drug-coated balloon. Every one of these mandate some duration of dual antiplatelet therapy, not anticoagulant therapy. And you can see here as trials have gone on, this temporal trends analysis shows that we are seeing more and more trials mandating this with time. Similarly, also in every IFU, for every one of these devices, mandate dual antiplatelet therapy for at least 1 to 2 months after a placement of the device. What about real world data? Well, this is data from my colleagues at Beth Israel looking at the Vascular Quality Initiative. And just to show you how dual antiplatelet therapy is being used in a primary surgical group after endovascular intervention, 69% of patients are discharged on DAPT, and 58% remained on DAPT at 1 year. And they did find some small benefit for patients with CLI if you remain on long-term DAPT. But really, I want to emphasize here the prevalence of use even among the surgical colleagues. How about in the XLPAD registry with Subhash Banerjee? And again, here about 8% of patients received antiplatelet monotherapy after endovascular intervention, meaning that more than 90% received DAPT after endovascular intervention. And they didn't demonstrate a reduction in cardiovascular or limb-related events between short and long DAPT, but nonetheless, this clearly is the precedent in our community. So do we need vascular Xarelto, low-dose Xarelto early after PVI? Mark's gonna get mad at me for doing this, and I apologize. On the left here is clopidogrel. So in the red is clopidogrel and aspirin. In the purple is clopidogrel, aspirin, and Xarelto. On the right is no clopidogrel. So now we're just looking at aspirin versus Xarelto and aspirin. And so I'm gonna do something he's told me not to do many times, and I know better than, but I'm gonna do it for a debate. I'm gonna take away, first off, this first 30 days. Look at the first 30 days. We see no benefit. So early on, really no benefit with Xarelto. I'm then gonna take away the arms I don't care as much about. We're gonna now look at non-randomized. These are not randomized comparisons here, but for efficacy through 180 days, there's no difference between two cohorts of separate patients, not risk adjusted, but separate patients who had similar event rates, either on clopidogrel and aspirin or rivaroxaban and aspirin. Let's do the same for bleeding. There was clearly worse bleeding if you got triple therapy, clopidogrel, aspirin, and Xarelto versus just Xarelto and aspirin. And there was worse bleeding if you got Xarelto and aspirin versus aspirin alone. Let's look at the arms of our interest here. We're not supposed to do this, and I apologize, Mark, but again, bleeding rates lower, efficacy the same if we look at the clopidogrel aspirin arm versus the rivaroxaban and aspirin arm. So I'm just gonna end my talk just talking about cardiovascular event reduction and dual antiplatelet therapy. Again, not a new topic. We looked at this in the Charisma trial. Deepak Bhatt looked at the negative Charisma trial, but focused on a group of patients who had either prior MI, stroke, or symptomatic PAD. And we saw a nice event reduction for people who stayed on clopidogrel and aspirin through 30 months. And this is actually just the PAD patient population, which was published separately in the EHJ. And if you stayed on aspirin and Plavix for 30 months and had PAD, you had lower MI and hospitalizations for cardiovascular events. Someone named Mark Banaka looked at this in the Pegasus trial, which was a randomized trial looking at ticagrelor with aspirin versus aspirin alone among patients who had prior MI. And in the PAD population, there was a nice reduction in cardiovascular events with ticagrelor therapy, as was also seen in the general group of patients. And specifically, if you looked at major adverse limb events among patients with PAD, dual antiplatelet therapy with ticagrelor and aspirin for over 1,000 days reduced the risk of MALE, okay? So DAPT does have a role here. What about in the DAPT study? This is a study I did while I was a fellow. And again, we showed consistency here. Again, higher event rates for PD. These patients are sick, but consistency in the reduction of event rates with prolonged dual antiplatelet therapy, both for MI and stent thrombosis, as well as major adverse cardiovascular events. And lastly, in the Prodigy randomized trial, they also looked at PAD population with long-term DAPT. Here on top is short DAPT in gray and prolonged in orange. You can see a nice reduction in the PAD group without actually in this trial an increased risk of bleeding. So that was unique. So there is precedent that both DAPT reduces long-term cardiovascular events and can improve short-term safety. Why do we need Xarelto then? And although it's a poor, underwhelming 2B recommendation, dual antiplatelet therapy is in the guidelines as something to consider for our PAD population, both who are getting procedures and not. So I'll stop there. I wish you luck, Mark, on your review here, and I appreciate the opportunity to speak today.
Great. Well, thanks, Eric. I mean, I'll go ahead then and maybe talk a little bit about the same topic here, but from a different perspective. And I think, you know, I think that Eric, we're friends and colleagues, and so I think this is a good discussion to have. Can you see my slides, by the way? Is that are those visible? Yeah, good. I think what we heard was a good example of if you torture the data enough, eventually you can get it to confess to anything. But I actually have a good news story, which is now we actually have robust randomized data in PAD. And I think a couple of things that we have to think about here are peripheral artery disease patients are not the same as coronary patients, and coronary stents and coronary interventions are different than peripheral interventions. And I think it's been a confusing field because we think about trials that look at MACE outcomes, we look at trials that look at limb outcomes, and we're trying to confuse the two. And I think that that's natural because, as the guidelines say, we haven't had a lot of data. Now we do have some data. And I think it's worth discussing because there probably is a role for both agents. But how do we dissect the data and determine what the standard should be? I want to begin with an observation that the majority of trials evaluating antithrombotic therapy in peripheral artery disease involve subgroups of PAD patients in large coronary trials, and you saw a bunch of them, including the DAP trial. The endpoints were MACE, cardiovascular events. There were few limb outcomes if they were captured at all. In general, stable patients, and really unclear safety in the peripheral procedural setting. But the question I'd ask Eric and others is, why are you prescribing anything in the procedural setting? And of course, it's not because you want to reduce all-cause mortality 5 years later, because clopidogrel has never been shown to do that in any randomized trial, right? But it is to prevent thrombotic limb complications. That's what you're trying to prevent. And you can see that the burden, even in stable populations, is quite high relative to MACE. Now, Eric is right that warfarin has not had a good history in peripheral artery disease. One other illustration where the coronary and periphery divide, we have good data that warfarin actually works in MI patients. In PAD patients, warfarin is really a way to cause a lot of bleeding with no efficacy. But low-dose anti-10A inhibition with low-dose rivaroxaban is a different animal. And we can see in the COMPASS trial where there was overwhelming benefit. In fact, the trial was ended early for overwhelming benefit. There was consistent effect in peripheral artery disease, including for major adverse limb events, including major amputation. Now, did COMPASS drive broad adoption in peripheral intervention? No. Why? Well, the major adverse limb events admittedly are low in this population. It's a stable population. There wasn't any P2Y12 inhibition allowed, and there probably is a role for both. So how do you know what the safety is? And particularly, what's the safety in the procedural setting? I will say one observation from COMPASS was that that those patients who had had a revascularization, even if years ago, remain at a very high risk of adverse limb complications. And so that there is an adverse phenotype here. Once you've done an intervention to a patient, they've clearly been identified as somebody different in terms of limb risk. And I think this is the true story. We're learning that the PAD intervention patient is the ACS equivalent of the coronary patient, right? Once they've had an intervention, as you can see on the left, there's a very high upfront risk of major adverse limb events. And even long-term, that profile never returns to the risk profile of a PAD patient who's never had an intervention, and it far exceeds the risk of MACE. And these are bad outcomes. Acute limb ischemia is associated with long hospitalizations, amputation, and high rates of mortality. In fact, the outcomes are worse than what we see for acute coronary syndromes. If you think of ALI versus STEMI, these are both a complete occlusion where time is muscle and your outcomes are really determined by the time to reperfusion, but actually the mortality rate, MACE rate, recurrent ALI rates, and everything are worse for ALI. So this is a bad event. So the revasc patient is different, PAD patients are different, and ALI and limb outcomes are bad. So what do we know about DAPT? And with all due respect to MIRROR, 80 patients of an unblinded intervention really don't give us a high quality of evidence, especially when we see trends for all-cause mortality, where again, clopidogrel has never prospectively shown a benefit. Even, Eric mentioned the DAPT trial. We certainly didn't see a reduction in mortality there with clopidogrel. So I think that's probably not real. Now, when we look at interventional settings, albeit here surgical, because we don't have endo, we see that there really is no benefit on the left to aspirin and clopidogrel versus aspirin alone, or to warfarin, as Eric said. There's no benefit. But what do we do know? Well, there is clearly more bleeding, both for clopidogrel and for warfarin, and that actually there are trends to higher cardiovascular mortality with clopidogrel probably related to bleeding and things that happen after bleeding. And so it's in the guidelines because we do it, because we haven't had good evidence, but there isn't really a strong evidence base to justify doing this to patients. So what did Voyager tell us? Well, I think you can see that the addition here of rivaroxaban to aspirin versus aspirin alone, with or without clopidogrel, clearly reduces the composite of limb and major adverse cardiovascular outcomes. This is over 6,500 patients. This is a pragmatic trial, claudicants, CLI, endo, surgical, consistent benefits no matter what. And even at 6 months, you see a number needed to treat of 65 with an absolute risk reduction of 1.5%. And this only gets better over time to a number needed to treat of 39. There is bleeding, but that bleeding actually is modest in terms of the absolute risk increase, on the order of about 0.25% per year, or maybe about 0.6% per year if you're thinking about a very sensitive bleeding outcome. And so overall, there's about a 6-to-1 benefit risk ratio of this strategy in an all-comers population. Again, this isn't a subgroup analysis. Now, what about the endpoints that we're really thinking about here? If you look at the second set of bars, what is the likelihood your patient's going to come back needing an unplanned revascularization in that limb you just did something to because they're having recurrent ischemia? That was reduced by about 2.5%, statistically significant. What is the likelihood in the fourth set of bars of preventing or extending event-free survival with all-cause mortality? 2.6%. So consistent benefits, including for VTE on the right, where although it was in the hierarchy a nominal p-value, we see broad benefits of this strategy. This looks very different than warfarin, and very different than warfarin looked in the coronary trials, from the 1980s that were presented earlier. This is a different strategy. And when you look at this strategy, again, if for each year of treatment, you're preventing 181 events for 29 bleeds for 10,000 patients treated, but I'll draw your attention to the right. The question is, how early do you see the benefit? And actually, if you look at the graph here, by 90 days, you've already prevented almost 150 events. And although the bleeding stress test occurs early, bleeding is flat over time. If you actually look at this curve at 30 days, you have a significant number of events prevented. So the benefit is present quite early. And in fact, if you look at these, so let me just stratify now by clopidogrel. And Eric did this. He did some things that he's probably not proud of, comparing non-randomized left to right here. And I think, all's fair in debating, but I think we know that's not the right thing to do. But I think the question is here, is there effect modification? Is clopidogrel doing a good enough job where you don't need rivaroxaban? And the answer is no. I mean, the hazard ratio is exactly the same. If clopidogrel was the answer, you would see attenuation of the benefit. You would see effect modification, and you don't. The benefit in absolute terms is also roughly the same. What about the limb outcomes? What are we really treating? Well, acute limb ischemia here. If DAPT was efficacious for preventing ALI, then why is the benefit of rivaroxaban consistent regardless of background clopidogrel? If clopidogrel were enough, you wouldn't see a 37% reduction with rivaroxaban on top of clopidogrel. It's clearly not doing enough to protect the patients. In addition, when you look at thrombotic hospitalizations, which really captures the issue here, when you look on top of clopidogrel here, I'm showing you 90 days, there's a more than 50% reduction on top of clopidogrel at 90 days, which was around the median time here. So even at 30 days, when you look at these curves, you see separation. So this trial was not designed to tell you whether clopidogrel works or not, but it does tell you that rivaroxaban clearly is a better solution to what we've had before, and that the effects are the same whether or not you use clopidogrel. As Eric said, there is an effective clopidogrel, and that is more bleeding. And I think it's intuitive to say 3 drugs causes more bleeding than 2 drugs, although we don't see the similar pattern for efficacy. And when you take it all and you put it together, the clear answer is rivaroxaban is beneficial whether or not you choose to use clopidogrel on the left or you don't choose to use it on the right. And there's a net benefit even on the left with using clopidogrel, an absolute risk reduction of 2.3% and an increase in bleeding of 0.4%. So net benefit no matter how you slice it. And so that rivaroxaban should be the standard of care. So in conclusion, Rivaroxaban plus aspirin reduces MACE, it reduces ALI, and the need for unplanned revascularization. It has a clear net benefit with a 6-to-1 benefit risk ratio. And this really should be the standard of care in this population, in this setting. There's clear data now that we have a beneficial strategy. The benefits are consistent regardless of background DAPT. And I think if you're wed to DAPT for many of the reasons Eric said, you can use it, but it's not strong enough alone to protect limb and life in this setting. It doesn't do a good enough job to attenuate the benefits of rivaroxaban. So whether you choose to use DAPT or not, you should still use rivaroxaban. I personally would say that the absence of strong data supporting DAPT in this setting, coupled with clear bleeding risk, Casper showed you that, and so does Voyager, I would tend to use the shortest duration of DAPT that you can, and then continue on rivaroxaban. Thank you.
Thank you very much, Mark. Sorry, I had to step away to take a call from the hospital. But that was Dr. Mark Bonaca, Executive Director of the CPC Clinical Research and Assistant Professor of the Division of Cardiology at the University of Colorado School of Medicine. Two great talks, extremely timely discussion about clopidogrel and Riva. Any questions from panel members?
So, Raj and Dr. Bonaca, and of course, Eric also, this is a fundamental change in the paradigm of how we treat our post-peripheral intervention patients. And obviously, overwhelming majority of us are not doing it. Should we be doing it? And again, I bring back the favorite question, what about the cost to the patient? What the patients are already complaining about the cost of all sorts of medicines.
So I'll say that you know, there's sort of two parts to the question. One is medically, what's the right thing to do for the patient? The second is what's the cost and risk benefit? You know, I think that if the desire is to improve outcomes after peripheral intervention, this is the strongest data set that we have, and there's clear benefit and net benefit. In terms of the cost to the patient, there have been some cost analyses done, and there's an abstract that's been submitted to AHA, which shows that this strategy saves around $2,000 a year because in patients overall with PAD, because it reduces rehospitalization for repeat revascularization. We know that costs a lot of money. And so prevention is worth, an ounce of prevention is worth a pound of cure. So even though the drug costs money, overall it's a savings.
Yeah, so Mark, is there a risk profile that you would take into account, and even Eric can also chime in, where, you know, if you have a simple SFA lesion and we're gonna do a balloon or a stent, you know, and then there is not, you know, patients doesn't have CLI, is young, would that patient be given Riva also versus a patient who clearly has, you know, previous bypass, the bypass is occluded, now we have to thrombolize the graft, the graft is opened up and the patient had multiple revascularizations before. So in a spectrum of risk, you know, is there a difference on which patient would you pick over the other?
Yeah, that's a great question, because, you know, I think, and we heard the same thing in Compass, that the drug kind of works in everyone. The relative risk reductions are the same regardless of if you're a claudican, if you have CLI, and so on. And that's actually true. We see that in Voyager, that the relative risk reductions are consistent. That being said, Raj, it's a great question because the absolute risk profiles of these patients are different. And if you have a claudicant with no coronary disease, has a short segment lesion, you know, that patient's risk profile looks very different than someone coming in with CLI. And therefore, the absolute benefits of any strategy are going to be smaller, and especially relative to bleeding risk and cost. And I think with any strategy, there is a benefit to risk stratification and understanding that. And we're working on that in the trial, both in the using clinical characteristics, but also angiographic characteristics. And we hope to provide more data around that. I would say that you're probably going to want to do something after intervention no matter what, whether it's DAPT or Riva. I would say the data are stronger for Riva. The question may be how long do you want to continue it? And that may be determined more based on who they are rather than what you did to them.
Yeah, and just to chime in on that, I mean, I think that's been the biggest question among the interventional community is that you have a fantastically large trial for a peripheral vascular intervention, never been done before, but you also have a mixed bag. You have endo patients, you have bypass patients, you have CLI, you have claudicants, you have stents, balloons, atherectomy. So how do you put that all together? Because all of us who do these procedures know that each of those procedures end in a different way. Sometimes we feel really good about it. Sometimes we feel less good about it. Sometimes we're worried about clotting. Sometimes we're not. Sometimes we're worried about bleeding. So, you know, I think it's, you know, with with the trial investigators and the group, we want us to be for everyone. But I think we need a lot more of these details to tailor our approach, especially in that first 30 days. I think that the data long-term is there. I mean, I think I found that after Compass that Xarelto 2.5 BID is the right medication for PAD patients in the long term. My biggest concerns those first 30 days is what's the right drug for the right patient until we get out of that procedural time point.
One issue though is that in Voyager, those curves look to separate relatively early. They continue to diverge, but they separated within those first 30 days, right? Or like you see how there's this takeoff that happens there where they kind of move away from each other, right?
The problem with debating the guy who ran the trial is he has information to different slide deck than I have. There was some early benefit, but remember that's a composite endpoint. And again, we're thinking about device safety, and we worried about this a lot for the triple therapy trials for coronary stents about dropping aspirin early on. And there's been a little bit of a movement now to keep triple therapy back to 1 month, because once you actually look at an underpowered event like stent thrombosis, then you start to see that there might be some harm for stopping DAPT early. So, again, that's a tough one to look at, Jay. And I think that Mark has showed some evidence that maybe I'm wrong, and maybe I'll learn more as more data come out. But that's where we're really paying a lot of attention with the Voyager data right now.
There is one question from audience that's worth bringing it up. Dr. Victor Aldana is asking to Dr. Bonaca, what is the main clinical applications and which is the main difference between the Pegasus trial versus Compass PAD trial? And I mean, to which patient would I apply each study?
Yeah, that's a great question. I see Compass and Pegasus and DAPT and all these trials as actually complementary, not competing. And they tell you a couple of clear things. First of all, the polyvascular patient, the PAD plus CAD is extremely high risk for MACE, and they need more than one agent. I truly believe that. And then I'm talking about for MACE outcomes. And that's what all these trials were, right? None of them were designed as PAD trials per se. I think that, there is clear data for potent P2Y12 inhibition after ACS. There was a mortality benefit in the Plato trial. And that in patients from Pegasus that had polyvascular disease or high-risk features, there's a clear long-term benefit to continuing on. And I think that's a very reasonable strategy. Switching drugs at 12 months, from one to the other probably is not the best strategy for a patient. We like to continue on. Switching can cause bleeding or thrombotic events. That being said, there's a whole huge population of patients out there that aren't 12 months from ACS, that have stable coronary disease, that have polyvascular disease, and so on. And they don't have an indication for P2Y12, and I think the Compass strategy has really, really great data, and I use that frequently. And so I think that the right patient for the Pegasus strategy is post MI on ticagrelor, tolerating it well, and they have polyvascular disease or high risk features, continue on. I think for Compass, it's the patient that comes into clinic that has this polyvascular disease, diabetes, maybe not a recent MI, they're on aspirin alone. You want to add something. I would add Riva. I wouldn't add ticagrelor in that setting. And then I think the DAPT trial kind of supports that, where the post-MI subgroup really showed the benefit. And I think Voyager is just a completely different population and setting, and kind of speaks for itself.
Okay, well, thank you very much. There are several other questions. I think I'm going to have to hold them back given the interest of time. We're already a little bit delayed. So now it's my privilege again to invite Umberto Campia again, who is going to take the pro side on proximal deep venous thrombosis, no role for endovascular intervention. He's the assistant professor of medicine at Harvard Medical School and at Brigham and Women's Hospital. Umberto is going to take a con side proximal DVT, no role for endovascular therapy.
Oops, sorry, I unmuted. Thank you so much. And first of all, I would like to, again, express my gratitude for being here, such an esteemed panel of people. And so I will have a hard sort of challenge again in this debate. And I would like to make sure that we clarify the scope. It's not that I don't think that endovenous intervention have no role, but they have a very specific role, and the trials that have been published so far have given us a very clear answer to one specific question that they were designed for. Iliofemoral DVT is a clinical problem that we encounter very frequently and accounts for about 25% of all cases of deep vein thrombosis. And compared to more distal DVT, popliteal, and calf DVT, iliofemoral DVT is associated with worse outcomes, and particularly the post-thrombotic syndrome, which is frequent, up to 50% of patients, and potentially a disabling sequela that causes pain, discomfort, disability, and ulcers, which represent a very big burden on our workforce. And all patients with acute iliofemoral DVT should receive anticoagulation, and obviously unless there is a contraindication. And I'm not going to expand too much on the standard treatment of iliofemoral DVT, and I'm going to focus on the possibility that additional treatment with catheter-directed thrombolysis and endovenous approach reduces the development of post-thrombotic syndrome in this population. And obviously, this is a very important topic and has been the subject and the focus of a number of clinical trials. And I'm going to review now the main results of the main trials. So the first trial that was published in 2012 was the CAVENT study, and it was an open-label, multi-center, randomized controlled trial that enrolled patients with the first-time iliofemoral DVT within 21 days from onset of their symptoms. They were randomly assigned to conventional treatment alone, which is mostly anticoagulation, or the conventional treatment plus additional catheter-directed thrombolysis. The two co-primary endpoints or effect variables of the study were iliofemoral patency after 6 months and the frequency of post-thrombotic syndrome at 24 months. And the definition of post-thrombotic syndrome was the standard definition using the Villalta scale. The study also looked at some secondary effect variables, particularly bleeding as a safety, and recurrent VTE as an efficacy, and also the post-thrombotic syndrome at 6 months. Here on the left, we have just a summary of the Villalta scale for the assessment of the post-thrombotic syndrome. And we can see that there are patient-rated symptoms and clinician-rated signs. And each of them is a scoring based on the absence, 0, the presence of mild, moderate, or severe symptoms or signs. And a score of 5, or less of 5, is non-diagnostic for post-thrombotic syndrome, but a score of 5 and above is diagnostic. And depending on the score, the post-thrombotic syndrome is divided into mild or moderate, or up to 14, or if a score is 15 or more, this would, or if there is a presence of venous ulcer, this would be a severe post-thrombotic syndrome. On the right panel, we can see the sort of, oops, it moved without. Okay. And we can see that the breakdown of the two groups that were included and randomized, and about 101 were allocated to the additional catheter-directed thrombolysis, whereas 108 were allocated to standard treatment. And we can see that at the end, 90 patients were included in the catheter-directed thrombolysis for intention to treat analysis, and 99 were included in the standard treatment group, again, for the intention to treat analysis. If we look at the main results of the studies, when the two groups were compared, we can see that the occurrence of post-thrombotic syndrome at 24 months was less frequent in patients who had received catheter-directed thrombolysis compared to those on standard treatment alone. And this was statistically significant. Also, the iliofemoral patency at 6 months was also statistically different and higher in patients that had received catheter-directed thrombolysis. However, at 6 months, there was no difference in the post-thrombotic syndrome. So the CAVENT was the first trial showing that was a clinically significant reduction in post-thrombotic syndrome in a strategy using catheter-directed thrombolysis compared to conventional treatment alone. And there was an absolute risk reduction of 14.4% of the risk of post-thrombotic syndrome. So 7 patients are needed to prevent the occurrence of one post-thrombotic syndrome. And there was a small increase in the bleeding risk as expected in strategies that uses thrombolysis. Now, based on the results of the CAVENT trial, or based on the importance of the topic, the ATTRACT trial was conducted in the US to look at similar outcomes and with the use of a similar approach. So the ATTRACT trial was a multi-center randomized trial that enrolled patients with symptomatic proximal DVT. In this case, also the femoral, common femoral, iliac vein DVT were specifically enrolled, and the symptoms had a duration of 14 days or less. Patients were randomly assigned to anticoagulation alone with the use of compression stockings that had a 30 to 40 millimeter mercury of pressure, or anticoagulation and compression stockings plus pharmacomechanical thrombolysis. The primary efficacy outcome was the development of post-thrombotic syndrome, again, using the Villalta score of 5 or higher, or ulcer development, at any time between 6 and 24 months. And we can see in this figure on the left, to enroll 692 patients that were randomized, almost 29,000 patients had to be screened, and that indicates how challenging at times it is to enroll patients in this type of trials. And if we quickly move down, we see that 355 patients were included in the modified intention to treat analysis that in the control group, and 336 were included in the modified intention to treat analysis in the pharmacomechanical thrombolysis group. And if we look at the results, and again, we compare the pharmacomechanical thrombolysis group on the left with the control group, we see that the primary outcome of post-thrombotic syndrome between 6 and 24 months was not statistically significantly different between the pharmacomechanical and the control group. When we look at some of the secondary outcome, there was a statistically significant reduction in the proportion of patients with moderate to severe post-thrombotic syndrome in the pharmacomechanical thrombolysis group compared to the control group. As expected, bleeding events were higher in the pharmacomechanical thrombolysis group compared to the control group. In addition to the results of the ATTRACT trial, another smaller trial that was conducted in Europe looked at similar outcomes. In the CAVA study was a multi-center randomized single-blind parallel trial, and again enrolled patients with a first-time acute iliofemoral DVT as symptoms of a duration of 14 days or less. They were assigned to standard treatment with ultrasound, accelerated catheter-directed thrombolysis, or standard treatment alone. And the primary outcome was the proportion of patients with post-thrombotic syndrome, again, with the same Villalta score of 5 or higher, that had to be present on 2 separate occasions, at least 3 months apart, or there was a presence of development of an ulcer at 12 months. And we can see that the study enrolled a much smaller number of patients compared to the ATTRACT trial, and less patient also than the CAVEN trial. And if we look at the bottom, only 58 patients were included in the per protocol analysis in the ultrasound accelerated catheter-directed thrombolysis, and 57 were included in the standard treatment only group. Similar to the results in the ATTRACT trial, when the 2 groups were compared, there was no statistically significant reduction in the occurrence of post-thrombotic syndrome at 12 months in the thrombolysis group compared to the standard treatment. And also when the mean Villalta score was compared at 12 months, the difference was not present. So in conclusion, the sum of the evidence from randomized controlled clinical trials does not support a role for endovenous intervention in the prevention of post-thrombotic syndrome. The results of ATTRACT may suggest that the use of an endovenous intervention may reduce the severity or the proportion of severe post-thrombotic syndrome, but the primary outcome was not achieved. Therefore, I think that the evidence currently is not in favor of using a catheter-directed or endovenous intervention as a standard of care in patients with iliofemoral DVT. Thank you for your attention.
Thank you very much, Dr. Campia, and thanks for such a large audience who sticked around in many different social media channels where we are transmitting to hear Dr. Vedantam. Dr. Vedantam is a very well-known interventional radiologist. He's professor of radiology and surgery at Mallinckrodt Institute of Radiology at Washington University School of Medicine. He was also the principal investigator for the ATTRACT trial, and he's assistant dean for clinical research as well. He is now going to take the side of endovenous intervention is beneficial in proximal deep venous thrombosis. Dr. Vedantam.
Well, thank you very much. It's a pleasure to be with you today, and I want to congratulate Dr. Campia on a topic very well presented, summarizing the main results from some important clinical trials. I'm trying to move my screen forward. And just have to figure out how to advance my slide. Oh, there we go. Okay, so just some disclosures there, mainly NIH support. So I think when we talk about, treating patients with a clinical problem of substantial severity, we have to sort of be careful about the tyranny and absolutism of randomized trials and their primary outcome assessment. We have to make clinical decisions based on an individualized assessment and applying those data to patients that we treat. And the first thing to remember with acute iliofemoral DVT is that it causes a lot of symptoms. People have a lot of pain and a lot of swelling, and they're at higher risk for post-thrombotic syndrome, more severe post-thrombotic syndrome down the road. We need to remember why we actually get called. Now, I've been doing this for over 20 years, and despite having an interest in this particular area, I'm trying to count, I can maybe count on one hand the number of times I've been called for someone saying, hey, Dr. Vedantam, please come do thrombolysis because I want to prevent the post-thrombotic syndrome in my patient. Now, that is what the trials focus on, of course, but really why we get called is someone gets anticoagulated and they get worse. And there is a minority of patients who are laying in bed and just can't get out of bed despite being anticoagulated for a while. In addition, there is a smaller cohort of patients who develop acute limb threat from phlegmasia ceruleus dolens. And we have to remember when we start to say that there's no role for more aggressive therapy, that many of the patients we get called for really don't do well with just standard therapies. They're at risk of amputation, as in the people with acute limb threat, or they just can't move despite being anticoagulated for a while. And so clearly there has to be some role for these therapies. Now, I want to get to the issues related to the routine first-line use of lytic therapy, as was alluded to in the discussion of the randomized trials as well. And again, the purpose really is to reduce the symptoms of DVT and to reduce long-term disability. Now, the ATTRACT trial that was discussed before, again, a large randomized trial, nearly 700 patients randomized with acute proximal DVT to receive or not receive pharmacomechanical therapy and followed for 2 years. And we need to ask ourselves when we talk about any randomized trial, well, really, why should we believe that trial? Why does it give us better information than what we can get elsewhere from our own clinical observations, from the discussions we have with our colleagues, from observational studies? I want to just take one quick moment and remember that the ATTRACT trial was developed by an incredible group of DVT thrombosis research leaders, among whom was Dr. Clive Kieran, who was the chair of the Data Coordinating Center for the trial, and really had a big role in designing the trial. He unfortunately passed away last week due to melanoma, and I just wanted to give him a moment of remembrance and respect for his incredible contributions. With people like Dr. Kieran on the trial, you have an advantage in the sense that you can improve the quality of the information you present by minimizing bias in the trial. And a lot of the design of the ATTRACT trial, really, there was operational separation of the conduct of the trial versus the data management. There was comparable use of anticoagulant, antiplatelet, and compression therapies in the trial. There were operational plans for equal surveillance of people in both treatment arms, and there was blinding of the assessors and the adjudicators of clinical outcomes, in addition to randomization and allocation concealment. Now, one very important thing about the ATTRACT trial to note is that we deliberately stratified the randomization up front by whether or not people had iliofemoral DVT, i.e. thrombus in the common femoral or iliac vein. So in both treatment arms, there's an approximately comparable proportion of people who had iliofemoral DVT, enabling a higher quality subgroup analysis. And in fact, that's nearly 400 patients. They're evenly distributed, again, in the 2 treatment arms. When we talk about precautions against bias, again, we strongly did try to minimize bias in the trial. Now, going through the results of that trial, what one finds is that early on, if we look at the change in patients' leg pain from baseline to 10 or 30 days, in the people who got lysed, it was better, statistically significant. If we look at that change in swelling, again, it was better in the people who got lysed. In fact, in the control arm patients, there was barely any difference at all from baseline to 30 days. Again, at 2 years, there was no difference in the occurrence of post-thrombotic syndrome. However, when you look at a slew of secondary outcomes that really relate to symptoms in a patient, both the occurrence of moderate or severe PTS, less in the lysed patients. If you look at the 2 ways we assessed severe post-thrombotic syndrome using the Villalta or Venous clinical severity scores, again, less in the people who got lysed, and that approached statistical significance if we use the more restrictive p-value of 0.01. If you look at the mean Villalta scores at 6, 12, 18, 24 months, and the mean Venous clinical severity scores at all those time points, at every time point throughout the trial, there was a reduction in the iliofemoral patients with statistically significant p-values. Finally, if you look at the change in health-related quality of life using a venous disease-specific measure from baseline to 24 months, it was better in the people who got lysed. And we know that we removed a lot of clot in those patients as well. And when you think about doing a trial, you have to pre-specify clinical outcomes. These were our pre-specified outcomes. Now, when you start to see differences, you have to be very careful in over-interpreting them. However, when you see a concordance of differences and a consistency and a pattern where all the numbers are leaning in one direction in a similar kind of way, you have to weigh that significantly. And again, this is just the tables that we chose to show you. The truth is that there are about 100 additional tables that I see as the PI of the trial. And look, the numbers, when you start looking at symptoms, the numbers all lean in one direction throughout those trials. Some hit the p-values and some didn't, but they all lean in the same direction, really. When you look at the change in health-related quality of life and you look at the pattern, the top and bottom lines here, the red and the blue, are people with iliofemoral DVT, and the ones that were randomized to receive or not receive lytic therapy. Within the first 6 months, there was really quite a large difference in health-related quality of life, 10 points on the VANES quality of life scale. When you get beyond 6 months, the difference is smaller, but it is still there. And in the per protocol analysis, it was even larger. When you look at the safety issue, again, in the iliofemoral patients, basically there were 3 major bleeds in the lysed patients, 1 major bleed in the non-lysed patients, which translates to about a 1% additional risk of a major bleed. Again, no fatal or intracranial bleeds, not a bad safety profile overall for a lytic trial. The doses that we used of TPA were a lot less than would have been used in the catheter-directed thrombolysis only type trials when we're using pharmacomechanical therapy, lower total treatment times, and again, now we've got newer devices to use as well. So I think you have a simple choice. You can take the Umberto way, where you leave clot in the deep veins, as you can see here, and where you have a higher occurrence of moderate or severe post-thrombotic syndrome, as shown by these pictures. Or you could take the Suresh way, where you have open veins and a lower risk of moderate or severe complications. So in conclusion, I think if you take the people with acute limb threat and the people that can't ambulate after initial anticoagulation, really how can lytic therapy have no role, as was presupposed? And then when you talk about the routine first line use, I think we have to remember that ATTRACT found pharmacomechanical therapy to be effective and safe in the people with acute iliofemoral DVT, a large improvement in early symptoms and early quality of life, a modest improvement in late symptoms and late quality of life. If we use it wisely with good patient selection parameters like we did in ATTRACT, the rate of additional bleeds is just 1 additional %. And we should remember that we finally have level 1 evidence, which we never really had before, to support the use of therapy in this condition. So I'll stop there and thank you very much.
Okay, thank you, Dr. Suresh. A couple of questions regarding this trial. As you could see, even though ATTRACT trial did answer the question, the worst thing that happens with any randomized controlled trial is when you have a fixed endpoint and the definition of the endpoint varies between black and white when you use Villalta score, which I don't think is the right way to interpret any of the studies where you have a variable that is from 1 to 10 and you are picking a fixed point within the trial to define whether it's beneficial or not. I think that was the biggest downfall of an ATTRACT trial. And I don't know what, personally, in terms of treating these patients, I do believe that iliofemoral DVT does benefit from getting thrombolysis. And if you had to do this study again, what would you put as the endpoint? Because on one side, the issue with pathophysiology of iliofemoral DVT is you are substituting an obstructive lesion to an incompetent lesion once you do that, because the valves are destroyed in the lower extremity. So if you are comparing the lymphedema or the associated clinical features of post-thrombotic syndrome, you're not going to see the benefit across the board in all the symptoms, but the obstructive symptoms are definitely gone. The reflux symptoms persist because now they have destroyed valves. And unless we find something that can replace that, we're not going to see the endpoints that we desire to see. So if you could comment on some of those, if you have to do the trial again, should we redefine how we read the trial back?
Sure. So I think it's a great question. So just to go back, I think that, again, the question that we asked in the ATTRACT trial was, we know that we're already using lytic therapy for people who, for example, progress to worse symptoms, right? But should we use it routinely upfront along with anticoagulation as part of our first line approach? And remember, you're talking about 100,000 people a year with, and you know, if you're giving lytic therapy, you're gonna have some disasters, right? So to justify the risk of an intracranial bleed, right, which you're gonna see, if you have a positive trial, you're gonna have a few hundred at least per year, right? There needs to be a very compelling benefit. And the only real compelling benefit one could define there would really be if you could prevent this condition, right? And so that was the most compelling thing, is can you prevent PTS altogether in a lot of people to justify the fact that you're gonna kill or disable, right, a small percentage of them, right? So that's the reason to use a binary outcome. The second reason is that if I came back to the community and told them what we found in the ATTRACT trial is that, look, PTS severity, the Villalta scores were reduced by 1 point, with a mean of 1 point on a 33-point Villalta scale, which is what the data shows. I think the medical community would come back and say, well, 1 point, what the heck does that really even mean? I don't even know what that means, right? And is it large or is it small? And is it worth giving TPA to 100,000 people a year? We would not have the answer to that question. And so that's where the challenge was, and that's why we ultimately decided on a binary endpoint. Now, going forward, I do agree that we need to do better in the outcome assessment. I think the biggest challenge is not so much Villalta versus VCSS or whatever, but the mere fact that we're addressing and assessing PTS on 4 days for a condition that affects a patient every day for a 2-year period or longer, right? I think the bigger issue is what we need are ways to more comprehensively characterize the daily burden of the disease, because we know it waxes and wanes, right? And people miss one of those 4 follow-up visits that we do in a clinical trial. We now have smartphones, we now have sensors and monitors, and we really need to do better about developing physiological and other ways to develop more real-time holistic assessments of the daily impact of this disease on people's lives, and use those in clinical trials going forward. So I think I would take it away from, you know, the Villalta scale, people criticize, but quite honestly, if you look at the bulk of data supporting the fact that it measures what it's supposed to measure, it's overwhelming. There's, you know, at the time we submitted the grant, there were 17 trials, or studies validating that scale. At this point, there's literally over 50 probably. But the issue really has to do with, are we really getting a comprehensive assessment, right? And we can do better going forward.
The fact that multiple different ways of assessing the post-thrombotic syndrome tells us that we don't have a single method to figure out the venous hypertension, and people do suffer a whole lot with diseases that cannot be compared in one single measuring criteria that we come up with. And I think, what do you, if you have any idea about the ideal study that's being done in Netherlands, if they have the results out yet, or do you think that would answer some of the questions that were left open with the ATTRACT trial, especially with the popliteal to the ileal segment or the iliopopliteal segment that we definitely agree that wasn't a good outcome with the ATTRACT trial?
Yeah, I'm not familiar with the ongoing development of that trial that you're talking about. Again, the trial, the CAVA trial from the Netherlands was alluded to in the last talk, that looked only at acute iliofemoral DVT using ultrasound-assisted thrombolysis and didn't see any differences at 1 year, either in PTS or quality of life. It was a bit of a smaller trial, but they didn't see any differences at all. Now, it may have been too small to find a small difference in quality of life that may exist long-term, but unfortunately that wasn't able to demonstrate a benefit, compelling benefit either. I know there are other single arm studies that are being conducted now in the US, the idea or the theoretical idea being to develop another randomized trial focused on iliofemoral DVT. I do think that type of trial should be done and would probably be positive were it to be done. I'm hoping that someone takes the bait and does that study soon.
I have a question, Suresh Volkabnik. Congratulations on both speakers' presentations. There's a mention about the fact that when you do lytic therapy, you may have an open column and increased venous hypertension secondary to reflux. Do you think that obstructive phenomenon is more important in terms of developing symptoms and a higher Vialta score than reflux?
That's a very thorny one to walk through, obviously. Well, I do think that the obstruction of the iliac segment is very important. I mean, I think it's probably the most important thing in all of this whole equation probably is that. Having said that, the skin manifests, for that to manifest in skin changes, you probably do need to have some level, you often will have some level of transmission through reflexing vessels, right? And so, I mean, I think they operate together. I'll mention in the ATTRACT trial, we did a sub-study with ultrasound, and we did not see a difference in the occurrence of valvular reflux with the use of pharmacomechanical therapy versus no pharmacomechanical therapy. What's interesting is that in the COVENT trial, which seemed to have a little bit of a difference in post-thrombotic syndrome outcome, they did see a small reduction in the occurrence of valvular reflux, maybe from about 85% to 68%, and so it's kind of an interesting finding, and it does make you wonder whether there could be differences also between different endovascular means that are used to treat DVT.
Well, these are all great discussions and very pertinent issues. Thanks a lot, Dr. Vedantam, and thanks to all the faculty and participants. I think we've covered a very good range of issues. We'll conclude the session with thanks to all the attendees and panelists. We'll continue next week, June 20th, with the part 2 of the debates in vascular medicine at 8 o'clock Eastern time. And we look forward to having you all. And I think that debate will be in concurrence with Chinese Vascular Complex. We expect to about 3,000 co-attendees by virtual as well as from China. So look forward to having you all. Thanks to all, and we'll conclude.
Thank you.
Thank you, everyone.
Thank you, Suresh. It's been a pleasure. Thank you so much.
You too. Good.